Hi, good morning, everyone. It's my great honor and pleasure to speak to you today. And I would like to extend my sincere welcome to each of you for this APSL and AASLD Young Investigator Workshop. As we gathered today, as you know, the young investigator play a pivotal role in the future, shaping the future of our societies, APSL and ASLD. And I'm confident that educating the young generation is a cornerstone for our future. Then we have today's whole day meeting have 3 parts. First, we have a lecture series delivered by esteemed members, executive members of APSL and the ASLD. In the afternoon, we will have a breakout session where participants have an opportunity to present the data in front of the executive members of APSL and the ASLD with also senior doctors. You have 10 minutes for presentation and also 10 minutes for discussion. Because we extended the time of discussion to give you an opportunity to talk with senior members and enhance your knowledge about your study and discuss with expertise. After that, we will have a short lecture series followed by an awarding ceremony. I trust this opportunity gives you a great experience for your future and as an investigator in basic and clinical research. Thank you. Do you have her slides? I uploaded. Yeah. We're good? Good to go? Okay.
Good morning, everybody. My name is Ray Kim. I'm coming from Stanford University in the US, and I have the pleasure of co-organizing this workshop. This started in 2004. So been doing this about 20 years, and it's always energizing to be engaged in this activity. We're going to deviate a little bit from the program that you have, so we will adjust as we go along. But the first speaker remains the same. Professor Grace Su is a professor of medicine at University of Michigan. She also leads the GI section in the VA program. She has been engaged in clinical and translational research in liver disease. Most recently, morphomic analysis has been her interest, biomarker discovery in different areas, including HCC. So she has a perspective of being able to look across the landscape of liver disease in the world. And so that's the topic we asked her to address, which is, what is the hot topic? Where do you want to do research? So thank you for being here, Grace.
Thank you very much. Thank you very much for having me. It's a true honor to see the future of hepatology here. So today I'm going to try to talk about hot topics in hepatology research in 2024. I have no disclosures. So when Ray asked me to give this talk, I thought, what do I know about hot topics in hepatology? So like everyone else in 2024, what would you do? You, of course, would ask ChatGPT. So I said, what are hot topics in hepatology research? And ChatGPT came up with the sort of the average topics, and they're usually related to liver disease, topic types, genetics, precision medicine, and gut-liver axis. So I then asked, what about hot topics in Asia? And they came up with essentially the same list, but with the addition of herbal and traditional medicine, more about gender and ethnic diversity. They added public health interventions and technology. So as you can see, the list is very similar. But as we all know, you really can't trust ChatGPT. So the next thing I did was, I should ask my friends. So I went and phoned a friend. And I asked everybody, what are the hot topics for research? And the underlying thing that happened is everybody believes that the hot topic is the topic they're working on. So the most important thing is for you to believe in your topic and to have passion for it. So what constitutes a hot topic? It's anything that people find interesting. But there are some caveats. You might find it interesting, but it needs to be clinically relevant. It needs to be a rising problem with the knowledge gap. You need to have access to the innovations, the cutting edge methodology and technology, because you need all these things so that you can get funding for it. So clinically relevant problems. This is not an exhaustive list, but it has the most common liver diseases, and even uncommon liver diseases are important, unlike what ChatGPT says. And people can study many facets of this, including basic mechanisms, epidemiology, public health, and clinical translational. So what is a rising problem with knowledge gap? Well, one of them in the United States is the prevalence of obesity. In 2011, you can see already that obesity is a problem. So the green is when the obesity level, which is defined as a BMI less than 30 in the United States, is not present anywhere in the United States, even in 2011. There were very few states that were 20 to 25%. Many states were like my state, already at 30 to 35%. So this is a big problem. But what has happened in the last decade is even more traumatic. As you can see, over the last decade, the numbers of obesity has increased significantly, such that in 2022, this is what the map looks like in the United States. You can see that the majority of states have more than 30 to 35% obesity. And of course, what is associated with that? Metabolic associated steatotic liver disease. And this is not a United States problem. This is a global problem. You can see that the prevalence of MASLD is greater than 30% in many countries, including, surprisingly to me, Japan. So as part of this, globally, we've come together to try to define more specifically what MASLD stands for in terms of steatotic liver disease and separating them into alcohol versus non-alcohol versus metabolic associated disease. So we have this huge problem, but realistically, we all know that out of all the people with fatty liver, probably only 5% over 20 to 40 years will develop significant liver disease such as cirrhosis and HCC. And some people are slow progressors and some people are rapid progressors. And in reality, can we really can we have enough hepatologists to take care of every single person with fatty liver, and then recognizing that the majority of people are not going to progress? So we need to come up with the risk factors that lead to progression. And we have identified those risk factors, many of them, which are in this table, including genetics, presence of diabetes, visceral fat, gut dysbiosis, unhealthy diet, and alcohol. And these are very important factors, and we looked at underlying mechanisms for them. And as a result of our studies in the basic mechanisms, we now have a lot of treatments, potentially, for that can be directed at MASLD. And these are just beginning to blossom. In fact, the US just approved the first MASH-related medication. So is this the answer? We just give everybody medication? Realistically, we need to stop treating the disease. So we have medications to treat the disease, but we know that when we treat patients, we only get a certain amount that have the effect that we want. But the majority of people don't have an effect, and some even have an adverse effect. So that is the past, treating the disease. The future is treating the patient. And to do that, we need to have ability for risk assessment. And that is really the future of where our state is, to try to get everybody to the point, to the right treatment at the right time. But there's also another problem. Remember, I mentioned to you that, let's see, more than 30% of the US population and worldwide have MASLD. And who can take care of all these people? I know that in the United States, we don't have enough hepatologists for all that. So we have to rely on our first line providers, the primary care provider. But the problem is that most of these providers don't recognize this disease. In fact, if you look at the chart, it appears that only 14% had even given any treatment, which at the time is diet and exercise, to patients with MASLD. And more concerningly, the majority of people who come to liver transplantation, end-stage liver disease, present without ever knowing that they had MASLD until the time that they need a transplant, which is pretty astounding. Now, this isn't just a MASLD problem. Even prior to the treatment, prior to the availability of Hep C treatment, you can see that Hep C cirrhosis was not well documented, and that in the NHANES report, there were more than 50% who were even unaware that they had hepatitis C. In fact, this type of problem is very common because the liver is so quiet and stoic, and then it never expresses itself to the end. So the common problem with liver disease is that it is quiet until it's too late, which makes us even more important to come up with ways in which we can identify these diseases earlier. So we need to come up with innovative solutions to address this rising burden of MASLD and other liver diseases. And we talked about risk assessment so that we can identify the people who are actually going to have a significant liver disease, the high-risk patients, or we can potentially try to educate our first-line providers, the primary care providers, as we do not believe that everyone can be a liver specialist. And one option to do this is through electronic consultation. So you could potentially teach people through electronic consultation and perhaps decrease the burden on the hepatologist. But that doesn't really teach the person unless you do one other potential thing, which is the ECHO model, which has been described for many years, first in hepatitis C and more recently in liver disease, which is having the electronic consultation, but in addition to that, video conferencing with primary care providers to improve the knowledge transfer. And in this study, you could see that having an echo visit, a visit in which you're in this multi-person case finding study, that the hazard ratio was 0.54 for those who had a visit versus no visit in terms of improved survival. So that can be very effective. But there are many different ways in which we can be innovative to leverage technology to improve health delivery. So we know since COVID, I think in the United States for sure, and probably in all over the world, telemedicine is now a thing. We were forced to do it, and now we know that many of our patients can probably be treated through telemedicine, either with electronic consultation or with video conferencing with the patient. But there are other technologies as well, which are coming to the rise. Remote monitoring wearables. There are now ways in which people are studying whether you can use voice recognition to tell if somebody has hepatic encephalopathy. You can do non-invasive testing, which is increasing in numbers with transient elastography and other elastography methods through MRI, cross-sectional imaging. And you can do blood tests, standard blood tests like OPRI and FIB4 use standard laboratories. But there are also ones that use algorithms that involve multiple biomarkers, such as GALID, which has been shown to be effective to screen for liver cancer. And if you want to get even more innovative, there are many studies right now ongoing with liquid biopsy, because we realize that circulating tumor compartments are in the blood. And this could be ctDNA, circulating tumor cells, mRNA, microRNA, exosomes. These all provide the potential for diagnostic and prognostic application, and it will be the future for our field. Single cell technology has gone, escalated and actually has been progressing very well. And in fact, not only is there now single cell technology, but maintaining spatial transcriptomics is a thing and can have great impact for our knowledge for the future, as well as single cell proteomics. There's also been a revolution in image analysis. You can apply to diagnostic imaging, or you can apply to pathology. And everything underlying this image analysis is the following. Every picture that you see is made up of multiple pixels, and that's how you see them. So in a grayscale, you see every single pixel is represented by a number. So if it is white, it's 255. If it is black, it is 0. So you now have this digitalized, and you can mathematically calculate. So you can imagine that this can then be used to computationally decide a lot of analysis, which can be helpful when linked to clinical outcome. So radiomics is this type of field where you take an image, you digitalize it, get the feature extraction, you do high dimensional analysis, and then you relate it to clinical outcome, and it will be the future of image analysis in our field. Not only can you digitalize every image, but you can also measure all types of things within that image that was performed, including muscle features and fat features, which could be important for delineated biomarkers. So this idea is the omics approach. We no longer study one gene, we study the genome. We don't study one mRNA, we study the transcriptome. And as you can see, this can go on with almost every facet of what we study. But in order to do this, we need big data, high dimensional analysis. And within the artificial intelligence lies machine learning and deep learning, which are very important and becoming everyday part of our lives. So in the future, we can put all the data that we get, including those in the electronic health records, genetic markers, blood-based markers, transient elastography, and we can do prediction models based on our ability to assess risk. And of course, potentially we could have derivative such as ChatGPT, which can help us deliver medicine, although we're not quite there yet. But I would like to caution you. The data has to be, you have to be very thoughtful about the data, because it's not magic. What comes in will go out. So you need to be very clear about what you're actually putting in. The other concern, of course, is that many of these methods are black box. So you want to understand what is actually being used to make your risk analysis. And there's also a potential for increasing health disparity, because if your cohort does not have that diverse cohort, you will not have an algorithm that will work for all people. The other thing I would say is that a lot of this technology is fantastic. For me, I can get a video visit with my doctor and I don't have to leave my pajamas. But the reality is that patients who really need care live in rural areas, at least in the United States, with no access to technology. And so increasing disparity is a real concern with evolving technologies. And of course, last but not least, the ability to obtain funding is very important. But the key here to a hot topic for your research is your ability to feel passionate about it. What topic obviously is tempered by realistic considerations? What are your available resources? What are your funding source? This is a time for rapid change with onset of new technologies such as artificial intelligence, but we need to harness that prudently. Thank you.
Thank you, Grace. Can I have a question from the audience?
Thank you for the informative lecture. I'm Yoshimi Muto from Osaka, Japan. And I have a small question. I'm really interested in the gut-liver axis, but gut-liver axis, and is it hot topics in AASLD? And how can I develop it? For example, I will focus on the muscles with gut microbiome, or using AI, or how do you think?
So that's a very big question, but thank you for the question. Definitely, the gut-liver axis is absolutely very important and very interesting to the AASLD. You will need high-dimensional analysis, because the biggest problem with the microbiome is that there's so many bacteria, and understanding that hierarchy of bacteria and its effect on clinical outcome, I think, is very important, especially since you consider one of the challenges with the gut microbiome is that it changes very rapidly as well. So there's a temporal change, and I think, but it's definitely the hot topic for the future. It's a hot topic now, so.
Thank you.
Anyone else? So thank you. Thank you very much.
The next speaker is none other than our organizer, Professor Tateishi. He's a professor of medicine at Tokyo University. He's an expert in hepatocellular carcinoma. He studies the pathogenesis as well as work with patients in terms of their treatment. So I hope you feel that the workshop agenda is progressing from a very sort of a global topic to generic and then more skill-based as the day goes on. So the second topic is how to choose the right research question, Professor.
Thank you. Just a moment. There is no mouse. Excuse me, there is no mouse. Okay. Mouse がない。Mouse だ。Oh, okay. It's okay. Thank you. Thank you, Professor Kim, for your yes, the mouse disappeared. It's okay. Thank you, Professor Kim, for your kind introduction. I'm Dr. Tateishi from University of Tokyo, and it's my great pleasure and honor to be here and to organize this important sessions for young investigators. Today I'm going to talk about the clinical question or research question. I have nothing to disclose. Today's my talk have three parts. First, I'd like to talk about the value of a paper, what determines the value of paper. And next, I would talk about how to find your research question. And finally, I would like to talk about the SWOT analysis. It is common among the business persons. And I will focus on what is your strength, what is your strength of your team. So what determines the value of a paper? So I always show your young investigators these figures. I think the importance, value of a paper is represented by the importance of research question multiplied by the strength of the result. Both of the two are quite important. And the importance of research question consists of three parts. The first one is quality and quantity of previously report. And the problems that have already been solved are worthless, even though that question is quite important for patients. And how big the clinical impact is to outcome, you need to understand the outcome matters or not. And also generalizability is always important for any kind of science. And on the right panel, you can see the strength of results consists of also three parts. The most important one might be effect size, the impact of results on clinical decision making, and the magnitude of bias. That will be talked by the next speaker in detail. And also, we need to understand the confidence intervals for the result, because if the result have a wide, broad confidence interval, that is not so reliable. So I would like to talk about in detail. The first one, quality and quantity of previous reports. If sufficient evidence has been already accumulated, for example, the treatment for naive HCV patient, if the problem is quite important for patients, however, it has been already solved, so that is not important for scientists. The quality and quantity of previous records evaluated by the same criteria as I shown in the previous slide, and you need to evaluate the previous reports based on the components listed on the right panel in the previous slide, and you need to evaluate the maximum effective size and the bias and the range of confidence intervals. I have been involved in guideline development for more than 20 years, where I have formulated, we set the clinical questions for the guidelines. For example, HCC guidelines, we have about 50 clinical questions for Japanese guidelines. Then we need to make a formula for the literature search. Then we need to evaluate each topic and each article, and selected the article based on the pre-specified criteria. Through this process, I have learned that what makes your paper important and valuable and frequently cited. Then the importance of outcome always matters, because that for example, for most clinical studies, the death or survival is most important outcome, undoubtedly. But in some studies, outcomes such as, for example, for patient with NASH, cardiovascular events also quite important, and for patient with MASH also, or patient with chronic hepatitis B or C, cancer development also can be a primary endpoint. In cancer research, also you can see many papers describing the recurrence-free survival or progression-free survival that are often considered as a primary or most important secondary endpoints. In such cases, but you need to find strong evidence to prove the relationship between the surrogate markers like recurrence-free survival and the true endpoint as overall survival. For example, in HCC treatment, recurrence-free survival is also important, but you can treat the patient even after frequent recurrence, and you can extend the survival by local regional treatment. In such case, a recurrence-free survival is not strong endpoint to assess the true endpoint of death. As I mentioned in the previous slide, even if the research is on general liability always matters in any kind of scientific studies. Even if the research is on a specific treatment for a particular disease, you are engaged in a particular disease, if the content can be applied to other treatment or other diseases, the paper will have a broader range of indication, and it's more likely to influence more clinical decisions. And that means, for example, if you are studying immune therapy for liver cancer, and your findings can be applied to lung cancer or other malignancies, the findings can be cited by other investigators than hepatologist or hepatic oncologist, like general oncologist or scientists who are engaged in lung cancer or skin cancers. I would like to touch upon the biases and the inaccuracies briefly. I prepared the two scenarios. This slide shows the looks like a forest plot in a meta-analysis. And a diamond indicates the effect size. And we assume that we are comparing the treatment A and the treatment B. The left side indicate the treatment is better than treatment B. In the scenario 1, the truth is that there is no difference between the two treatments. However, when there is a significant bias, it seems like, as indicated in the diamond, it seems like treatment A is superior to treatment B. So you need to consider the presence of bias, and you need to investigate the study method to, to check how the biases are controlled. You may have several statistical methods that will be talked about by Professor Ip later. And for example, you have propensity score matching, or you have Cox proportional hazard model, or ITTW method can be applied. And you also need to, clearly show how the selection bias might exist. And in the scenario 2, it is two different scales of randomized control trial, for example. And the upper, lines, the horizontal line indicate the confidence interval that you can see here, the diamond on the upper line indicate the much stronger effect size. However, because the confidence interval is quite wide, and you can see the line crosses the no difference indicated by 1. On the other hand, the lower line may have a smaller impact compared to the first one, but the confidence interval is much narrower, and you can rely on the result. So the number of events or number of patients always matters, because you have when you have a large number of patients, you got the narrower, more reliable results. So you need to consider the number of patients or number of events, especially in a cohort study. So in summary, in the first part, you need to conduct a study with broad generality, hopefully, in areas of insufficient evidence or more important outcomes. Then we do talk about how to find your research question. As I mentioned, I have been involved in guideline development. According to the guidelines for guidelines, the clinical questions in narrow sense are limited to 4 ground questions. That is questions related to clinical decision making. In front of the patients, you need to make clinical decisions. That question should be related to such kind of questions, such kind of situation. However, a question like what risk factor for hepatocellular carcinoma, actually I have been engaged in this kind of studies and are called inner guidelines background question, and distinguished from the clinical question in the guidelines. However, you can choose either types of questions, because that background question is also quite important to develop the treatment of diseases, because of course you need to the background, and you need to know the background, and then you need to develop the treatment for a specific disease. Then I would like to recommend or refer to clinical question in guidelines, corresponding guidelines. For example, you can refer to AASLD hepatitis C guidelines, or MASH or MASLD guidelines. And you can see there are many clinical questions. However, it might be not realistic for you or your team to develop conduct a study truly answer to the question, because these questions remains questioned, because that you need to conduct a large-scale cohort or randomized control trial to give answer. And you need to, you might focus on a small topic, that consists, that are part of the, general question. And I always encourage the young investigator or doctors to make a brainstorming to find out your clinical or research question. For example, as I mentioned, this is clinical question number 10 for Japanese clinical practice guideline for HCC. The question is, what is the recommended treatment for a single hepatocellular carcinoma? Actually, we conducted a randomized control trial. It takes more than 7 years. Need to enroll the 300 cases in 92 participating hospitals. It takes quite a long time to answer this question. Then we got the recommendation as shown here, a liver resection or ablation is recommended for tumors less than 3 centimeters in diameter. For tumors more than 3 centimeters, hepatic resection is still recommended. But it is quite a tough work to give an answer to this question. And if you have a strong team, or if you have a strong consortium to answer this question, this is a number one task for you to give an answer to such kind of quite important question. I'd like to introduce the PICO. It's quite common for clinical question development in guidelines for guideline. And the PICO stands for patient, intervention, and comparison or control and outcome. For example, the patient, and the question is, what are the characteristics of the patient or population in your study? What is the target population? What is the condition of a disease of interest? For example, hepatitis or MASH or, chronic liver alcohol-related liver disease? And what is the intervention under consideration for this patient or population? And this needs a comparator shown here. What is the alternative for intervention? That is a kind of, that should be a kind of standard of care, or in some scenario should be a placebo treatment. And then, as I mentioned, what is the included outcomes? In some studies, as I mentioned in the previous slide, survival is always the most important outcome, but you can choose the recurrence or cancer development or sometimes, adverse events. When you're studying, biomarkers for diagnosis of a specific disease, the patient can be, for example, can be like this. Single hepatocellular carcinoma, as I mentioned, and intervention can be radiofrequency ablation, and the comparison is, comparator is hepatic resection. We actually compared both two studies in the past randomized control trial, and the outcome can be overall survival or recurrence-free survival. And we are performing the, considering the diagnostic test, and the patient can be a patient with suspected HCC, and the intervention, should be a new diagnostic biomarker you are now investigating. And the comparison can be old biomarkers like AFP or DCP, and the outcome can be a presence or absence of HCC. So, as I mentioned, there is a long way to prove the final outcome and the relationship between the intervention and the final outcome. For example, if you are conducting the surveillance for MASD or MASH, you need to enroll patient with MASH, and you have two options for to perform surveillance or not to perform surveillance. The true outcome should be overall survival of entire population, not those with cancer development. You need to, in that kind of study, you need to evaluate the overall survival. It might take 10 years or 20 years for a period. However, you need to, dissect these kind of long follow-up study into several parts. For example, you can evaluate the cancer development rates on the in the patient with MASH, and then you can understand. You can evaluate the rate, and you can also stratify the cancer development according to the risk factors. Then there might be several papers of survival papers that describe the survival rates after the diagnosis of HCC or cancer related to MASH or obesity. Then you can combine these two evidence to make an entire figure, unless you got much longer follow-up study. Or adverse events. Adverse events is also matters. For example, you are considering the cancer treatment, immunotherapy for advanced liver cancer. We need to evaluate all outcomes. That include, of course, the adverse events. If the treatment A is superior, even if treatment A is superior to treatment B a little bit, but treatment A is much more harmful to patients, we make a different decision, for treatment A. So the correcting the adverse event is also quite important, and quite important for guideline development, and quite important for, of course, the patients. So in summary, in the part 2, you need to structure your question with PICO and the analytic framework. That might be helpful for, specify your question to be answered in your study. So you might know the word SWOT analysis. SWOT, S-W-O-T, stands for strengths, weakness, opportunities, and threat. It's quite common in business situation. It's a bit classical classification, but I think it's quite helpful when you're considering your project. The entire figure can be divided into 2 parts by the horizontal line into internal origin and external origin. And then there is 2 aspects that is helpful and harmful. Strengths, and when you consider your strengths, your team may have a large data on a specific disease, or you may have leading techniques on certain areas, or you may have a large you are a member of a large consortium to follow up a specific disease, or you may have strong treatment options that is quite outstanding among the other competitors. And the weakness might be like that. You may lack experience in areas that are trending now, as presented by Grace. And situation is always changing quite rapidly. The most powerful strengths might be obsolete in the future. So you need to understand your situation. For example, Tokyo University has the largest number of radiofrequency ablation cases in Japan. However, we are ranked at 6 or 7 in immunotherapy in Japan, also in Japan. We need to consider the enrollment or attract the patients to come to a hospital with advanced HCC, for example. And the opportunity can be like that. Certain diseases are on the rise, as also presented by Grace. obesity or metabolic dysfunction associated diseases are on the rise. On the other hand, hepatitis C is decreasing, especially in Japan. Hepatitis B is quite stable. And also, we're seeing the emerging treatments for certain disease. For example, we got the DAAs for hepatitis C, and we also have nucleoside analogs for hepatitis B. But we are hoping to have a more powerful treatment for hepatitis B to give the patients eradication of the disease. And also we have immune therapy or combined immune therapy or molecular targeted agent for chronic advanced HCC. So we are, our areas of interest are moving from the local regional therapy to more systemic therapy. And the threat in the decrease in previously predominant disease, as I mentioned, chronic hepatitis C, or some other diseases, especially in Japan, the portal hypertension used to be more predominant 20 or 30 years ago. And I'd like to touch upon briefly the literature such as a marketing tool. I have been formulating, search formula in PubMed for more than 20 years. And as shown here, this figure shows the number of papers in PubMed over the past 20 years. And until 2016, as you can see that, there is a rapid increase in the number of published papers. And the number is further increased especially after COVID-19. So if you don't have a specific tool for, crawl in the information of, in a sea of information, you must be drowned in that kind of overwhelmed information of the papers. So you need to understand, like specificity and specificity. So in the guideline development, you need to select as much as papers without omission. So for that purpose, you need to formulate, more broad more broad terms to capture any kind of papers that are related to a topic. However, it is not sufficient. It is not efficient for investigators. So you can limit to the search into important papers or latest papers and specific topics. However, you might miss some important papers. So you need to balance these two aspects: a broader or limited number of papers you need to refer. And I'd like to briefly introduce the mesh. That is medical subject headings in PubMed. If you say a renal failure or kidney failure, for the same kidney failure, you will have to prepare many such formulas that you need to include the renal failure, kidney failure, renal insufficiencies, etc. So we need to unify the keywords. National institution, national medical library in America, in the United States, set a mesh for that kind of purpose. And where specially trained staff assigned 10 to 20 standard structure keywords to each or every document. And you can see the mesh database. You can click the homepage, start page of PubMed. On the right and the lower panel, you can see the mesh database. Then you can see this panel. And you can input your topic of interest here, and you can see the formal mesh word as shown here. For example, myocardial ischemia has several lower level of terms that includes coronary disease, or myocardial infarction, or myocardial ischemia, or such and such, and so on. And searching the higher level of hierarchy includes all lower level of concepts. And in the result of PubMed, you can see that such kind of mesh terms on the, when you scroll the result, you can find the mesh terms here, shown here. And you might find the asterisk terms that indicate the keywords that a paper is primarily concerned with. And the asterisk is a marker, and you can find the more major topics by searching this tag. And the TIAB is the title and abstract, and if your keywords are not listed on the mesh term, you can apply this tag to more broad keywords. But you need to prepare each variation for the terms. And the TA stands for Journal Title Abbreviation. And you can also, date of publication, especially it's quite important when you perform the guideline literature search, you need to restrict the, the area, duration of publication. And the other tags are shown here. You can, refer to the PubMed question and answer section and on the list. And you also can have a combined research as shown here using the Boolean terms like and or not. Then you also can perform the advanced search by clicking here to combine the result of your search. I strongly recommend to prepare the log of your research periodically. Actually, I have Excel files for the previous research as shown here, and I always indicate the date of the research. Then I can repeat the same research in a year or in a couple of years. And you can see the number of hits and the final number of your search formula. Then finally, I'd like to conclude my talk, and that's, as shown in the third topic, you need to develop a clear research question about your area of interest based on a survey of your surroundings and self-analysis. Thank you very much for your kind attention.
We have a time for one quick question and one succinct answer. Why don't we move on in the interest of time? Thank you very much, Professor Tateishi. Next presentation is a bit of a difficult topic that I gave to Professor Iwakiri. I strongly believe for us to have robust research portfolio, we need to have a broad understanding of what's going on at the biology level, and then translate to patient level care. So the topic is how a clinical researcher should read basic science papers. Professor Iwakiri is from Yale School of Medicine. She is a well-known researcher in portal hypertension in the basic science arena, and I think she speaks some Japanese too. Thank you very much.
Thank you, Ray, and thank you, Dr. Tadeishi, for this kind of opportunity to deliver this important topic. I have changed the topic slightly, the importance of basic science in clinical research. However, this new topic is also aligned with the original topic about how clinical investigator should read the basic science papers. Having said that, I'm going to talk about, first of all, after I talk about the importance of basic science research in clinical research, I'm going to discuss about the strategy or tips for reading basic science papers. And finally, I will conclude with how basic science knowledge advances
the careers of clinical investigators, knowing that many of you are young investigators. So I'm Yasuko Iwakuri. I'm a professor of medicine at Yale University, and I am a basic translational scientist. I'm not a clinician. My area of research, like Ray told, the expertise include the liver fibrosis and portal hypertension, focusing on liver vascular biology and endothelial cell biology. Although I am a basic scientist, I think I'm in a good position to talk about why, why it is important for the clinician to read basic science papers, because I'm interacting with many clinicians and physician scientists, and I really feel everyday life that the basic science knowledge in clinician really moves the science forward. So basic science is a foundation for the clinical research. And knowing the basic science really move forward the development of treatment option, new drugs, and so on. It also fosters the opportunity for the fruitful collaboration among the scientists, clinicians, and industry experts, leading to the innovative breakthroughs and giving the hope for the patients. The knowledge of basic science is not really benefit the patient care, but also important for enhance your career perspective, because that is increase your expertise and also advance your knowledge in, it's also helpful for the writing grants and so on too. So basic science in definition, it is a fundamental research conducted to expand our understanding of natural or pathological phenomena, often without immediate practical applications. There are many examples. Just to pick some in recent impactful finding is that mRNA vaccine for COVID-19 research. As you know, Dr. Katalin Carico and Drew Weissman's group was given the 2023 Nobel Award by their discovery of this mRNA vaccine application for the COVID-19 research, COVID-19 treatment. So originally, this mRNA as a sort of immune responses is found or discovered in vitro system, and then long time after that, and this was applied to the vaccine development for the COVID-19 research. And then another example would be the PD-1 immune checkpoint inhibitors for cancer therapy. This was also given the Nobel Award to Tatsuku Honjo. And discovery of hepatitis C virus and led to the development of really effective hepatitis C virus treatment. So this was also given to the Nobel Award to the Harvey Alter and Michael Horton and Charles Rice. So those are the sort of some example, but as you can see here that the finding of the basic science may not really be applicable in soon, but later time is very, very helpful. Okay. So if you as a clinician, if you know the basic science, it will be very helpful for if you have opportunity to link your clinical observation to the development of the innovative and effective treatment. So how basic science informs clinical practice in hepatology? So basic science research in hepatology provides the fundamental insight into the mechanism underlying the liver diseases, guiding clinical practice to develop innovative treatment. For example, endothelial cell dysfunction is known to lead to the portal hypertension. If you know the mechanism or what causes the endothelial dysfunction in portal hypertension may help to develop the effective treatment for the portal hypertension. And studies looking at hepatic stellate cell activation in liver fibrosis also help to develop the treatment for the liver fibrosis. And then studies in viral infection to hepatocyte is a fundamental discovery that animal cells are not infected by hepatitis virus, but human hepatocyte does. So this idea, or this idea, it helped to develop effective experimental models, and then led to the development of hepatitis C viral drug. So to connect the basic science knowledge to the clinical practice or clinical research, or vice versa, it's important to be in the it's important to be in the diverse expertise in the research team. So interdisciplinary research team is really important. And if the clinician has this basic science knowledge, it will facilitate the collaboration between the clinician and basic scientists in liver disease research. And the basic science knowledge also help to develop innovative project yielding clinical significance and mechanistic insight. I just, in a couple of next slides, I want to give you some example around me. So this is one morning, weekly lab meeting, and my lab consists of clinicians, visiting scientists, medical students, a clinician, a physician scientist, PhD postdocs, and so on. So when my postdoc, PhD scientists provide some in vitro or animal studies or results from those experimental models, it's really helpful that those physician scientists or clinicians give us insight into how those clinical or the basic science finding can link to their patient observation and so on too. Or they also suggest some drugs that could be helpful to test this basic science finding and so on too. So this interdisciplinary team or members is really helpful to move the clinical research moving forward. I just want to give you one of the example of the clinician who reads the basic science papers. So he's one of my trainees. He promoted to assistant professor, and he has a lab right now. He has a lab and a team of the investigator now. So his area of expertise in platelet biology and thrombosis and cirrhosis and portal hypertension. So this is an example of fruitful collaboration and research papers or project that was done without knowledge of basic science in the clinician, which is the Matthew's knowledge in basic science as a clinician. So during the COVID time, you know that the COVID-19 patient has increased cytokines in bloodstream, leading to the systemic inflammation, and also many severe COVID-19 patient has increased liver enzyme activity. So there are some indication of the liver damage during the COVID-19. And so Matthew got interested in this because in the lung, the thrombosis and high inflammation leading to the thrombosis is one of the key mechanisms of the COVID-19 pathology. And he wanted to look at the IL-6 transsignaling. IL-6 is one of the cytokines highly upregulated in the COVID-19 patient. And so with this knowledge, he led this project with the collaboration with multiple diverse investigators with their knowledge in pathology and bioinformatics and also platelet biology and so on too. So without Matthew's knowledge in basic science, this project was not really moving forward very quickly. So as a clinician, it's really important to understand the complexity of liver diseases and underlying mechanism so that you can link your observation, or clinical observation, to the development of the effective treatment and help the patient life. So the basic science plays an important role to understand this mechanism. So now I want to talk about the strategy for reading basic science papers. I might, this not make, if you have additional tips, or if you want to share any tips for reading a basic science paper, please do so after my talk. So as you know, it's good to, so if you read the Cell Nature or Science papers, it would be very good because this is a high impact journals, but it is very complex to understand the basic science in those papers. So so my suggestion is to pick up the journals that bridge the gap between basic and clinical research. For example, Hepatology International, APASL flagship journal, or Hepatology Communication and Hepatology, those are the AASLD's flagship journals, and then Journal Hepatology from the ESOL. And particularly, I want to recommend the Hepatology Communication here. Dr. Gyeonggi Zabo is the founding editor for this Hepatology Communication. Now, there's new editor, Dr. Kamen Won, sitting over there, and then she's going to give a talk later time, is the editor in Basic Science. I'm serving as associate editor for this. So these journals has both clinical and then basic science papers. So it's to start with understanding of basic science, to get familiar to the basic science, so you can just skim through those journals. This is a good part to start. And when you have those, so when it comes to the paper, probably it's good to read from the abstract or highlights or the summary illustration and so on too, to see if that interests you. And then you may probably read the discussion or so. And then if that interests you, then going back to the method and result section as well too. So if you think that reading the paper is too much, then you can look at the tutorials. Generally, tutorials give us a very short snapshot of the most updated or recent papers. So this is also another tool to start to initiate your get familiar to the basic science research. And so to do that, I think it's important to find the time, the small amount of time a day. Let's say 15 minutes a day. But at the end of the day, what I said by now is everybody knows about it, but the motivation is the key factors because you have so many tasks. You have deadlines, or you have family issues, or then so what? Why basic science now? Because you have more priority than that. But definitely, basic science will help you to promote your the career. So let's say, this is an example. So if you want to really commit to read the paper to promote your career, 20-hour rule may apply. So have you heard of 20-hour rule? So I'm just read the definition. So the idea of 20-hour rule is that it takes approximately 20 hours of deliberate and focused practice to become reasonably competent in a new skill. So while 20 hours may not make you an expert, it's enough to become proficient and confident in the basics of new skill. So this applies to like new things. For example, if you want to learn Japanese, 20 hours of study will give you enough to be, it's not expert, but reasonably enough expert, or like playing violin or guitar or whatever. So if you study like 15 minutes a day, and then probably 80 days, it takes 80 days. However, you already have some levels of the basic science knowledge. So probably 10 hours would be enough for you to become more like a sort of a semi-expert for the basic science. But still, you know, when you open your email, like inbox, and then at the end of the day, you feel like you didn't do anything, like you haven't accomplished anything. So, this phrase is quite important for get things done. So the eat the frog. So eat the frog is the idea that identify one challenging task, in this case frog, and complete the task first in the morning, eating it. So eating the frog is the process of identifying your most difficult task of the day and completing it before you do any other work. So this is one of the key things that you can probably start reading the basic science research. But this can applicable to any other task that you want to do a day. Okay, so this is the takeaway message. So basic science knowledge is important for your career, particularly for the young investigators. So you probably do retrospective studies. So for this type of studies, a plausible mechanism that leads to the realistic hypothesis is the key or critical things. And you may have the consulting opportunity for the pharmaceutical companies. So having the basic science knowledge will give you some so this is actually a great opportunity for having this consulting opportunity, because if you know some basic science idea, or like if you know some levels of the pharmacotoxicity and so on too, that make you look like some levels of intelligence. And then when you are writing the clinical application, the grant related to the clinical studies, if you include some levels of the basic science things linking to your hypothesis, that is also key for the successful grant application. And you may have the business opportunity if you have some basic science knowledge, and then you may open up the company with a connection to your clinical observation and so on too. So having the basic science knowledge will give you a bright future ahead of you. So finally, I'd like to thank my first trainees, Dr. Matthew McConnell and Xiaomjun Xu. So actually, my talk was generated based on the brainstorming with them. In Xiaojun, for example, I met him 2 weeks ago in Ventura, California, when I attended this Golden Research Conference. So I asked him, so what do you want to hear from this topic? And he said, well, I think the most important thing is the motivation. So the motivation part is the most important to get started the basic science reading for the clinician. Okay, so that's all from me, and thank you for your attention.
That was not a frog. It was a very good talk this morning. Any questions? If I can just clarify, I think it's great to have that 15-minute rule per day, but I can imagine somebody jumping around different topics, try to read 15 minutes and not really making progress. And I assume your advice is try to focus on the area of your interest, perhaps, but
Right.
I don't want to put words in your mouth. How do you use that 15 minutes most effectively?
Yes, I think you need to have a goal to start with. So for example, if you want to understand inflammation in, let's say, alcohol-associated liver diseases and so on too, so you want to probably put some milestone. Let's say today, we'll look at cells involved in this inflammatory condition in alcohol liver disease or so, and then next day probably signaling, or the third one probably more applications of animal studies and so on too, and finally clinical implication, things like that. So the milestone, setting of the milestone probably helpful.
Okay, anything else from anybody? Youngie, do you want to add anything, or are you okay? As somebody who was mentioned in the talk.
So I would say that talk to your clinicians and kind of try to invite them to basic research lab meetings is a very, very great way, I think, to bring them together. So particularly, clinical fellows and go both ways to have actually the basic science people go to clinical conferences, even in your own local area. I think that's the best way to kind of educate one another.
Thank you.
Right, it's a very good point. Thanks, Youngie.
Thank you, Esko. So this is a point where we deviate from the program a little bit, so that the fourth talk will be on the topic of validity, which didn't make it to the program. So we will have this presentation. We'll take a break just to give you a perspective, and then we will have a second session for the morning. So this presentation is scientific principles with regard to validity, biases, and errors, and it is to be delivered by Professor Won-Muk Choi. He is assistant professor at University of Ulsan. So I'm grateful that you're giving this talk today. Thank you.
Okay, thank you so much for the kind introduction. I'm Won-Muk Choi from Asan Medical Center, Seoul, Korea. And first of all, I'd like to express my sincere gratitude to Professor Ray Kim and the committee members for granting me the opportunity to have a talk at APASL in this beautiful season. So in this talk, I will discuss the important considerations in clinical research from the design stage to the analysis stage under the theme of scientific principles, validity, biases, and errors. So I will provide an overview of the factors that need attention and offer examples based on the studies that I have conducted. So the basic structure of any form of clinical research is composed of 5 essential components: study population, intervention, comparison, outcome, and study design. To ensure the internal validity of the study, all these 5 components should be clearly defined and designed. So populations are all people in a defined setting, such as chronic hepatitis B or hepatocellular carcinoma. A sample is a subset of a people from the population. And researchers aim to understand the characteristics of the populations, but often rely on describing characteristics of the individuals within a sample for practical reasons. They then make inferences from this data, assuming that the characteristics of the sample is very similar to the parent populations. So the representativeness of the sample and therefore its validity as a substitute for the population hinges on the method of selection. So incorrectly chosen samples may distort the characteristics of the parent population, leading to potentially misleading conclusions. So the goal of clinical research is to draw inferences from the findings in the study about the nature of the populations. So the degree to which the investigators draw the correct conclusions about what happened in the study is internal validity. And the degree to which these conclusions can be applied to people outside the study is the external validity or generalizability. When we plan a study, we should design and implement a study to maximize the degree of internal validity. So internal validity is determined by how well the design, data collection, and analysis are carried out, and it is threatened by auto biases, chance, and confounding. Another term for external validity is generalizability. It is an answer to the question, assuming that the results of a study are true, do they apply to my patients as well for individual clinician? So the investigator wants to know the cause of the disease. To consider the causality, the cause obviously associated with the effect. However, not all associations are causal. This figure outlines for association that must be excluded. These include bias, chance, and confounding. So randomized controlled trials are the gold standard for evaluating the relationship between intervention and an outcome. Key to this study design is randomization, which minimizes biases by ensuring that treatment and control groups are similar in all aspects for the assigned intervention. Correctly conducted randomization allows differences in efficacy to be attributed to the treatment. So therefore, randomized controlled trials provide the strongest evidence in general. However, RCTs are resource intensive and focus on short-term effects of an intervention among a small population. So observational, non-randomized studies, including cohort studies and case control studies, have a role when RCTs are not available, and when RCTs are available to quantify effectiveness and other real-world experiences. So cohort studies have the same anatomy as RCT, except the randomization of intervention and comparison. So historical cohort studies use a cohort assembled in the past and follow up to present to observe the outcomes. Historical cohort studies often use electronic healthcare data that have already been collected, which have become more available in the last decade. So the logic of these two types of prospective and historical cohort studies are identical. The cohort must be assembled before the occurrence of the outcome. Observational studies are less resource intensive in terms of patient, fund, and time. However, even with the best of designs, observational studies are vulnerable to the possibility of misleading conclusions because of chance, bias, confounding, and the reversibility of effect-cause relationships. So from now on, I will discuss bias, chance, and confounding, which can significantly compromise the internal validity of the observational studies. So chance is a random matter. Chance operates bidirectionally. So increasing the sample size can mitigate its effect. However, bias is a systematic error. If we have a blood pressure cuff that have the measurements deviated to the right side to the real blood pressure, this is a bias which cannot be overcome by increasing the measurements. So in this case, we have to improve the study design. So these two sources of errors are not mutually exclusive, but both are present in most situations. So although dozens of biases have been defined, most fall into one of three broad categories: selection bias, information bias, and confounding. Selection bias occurs from any error in selecting the study participants and/or the factors that are affecting the study participation. So as a consequence, the relationship between a disease and exposure differs between those included in the study and those potentially eligible for the study. Information bias occurs when the methods of measurements are dissimilar among groups of patients, and confounding occurs when two factors travel together and the effect of one is confused with or distorted by the effect of the other. So confounder is a factor that is associated with both cause and effect. For example, alcohol was identified as a risk factor for coronary heart disease at initial investigation. However, drinkers more tend to smoke, which actually increases the risk of heart disease. And in fact, alcohol decreases the risk of coronary heart disease. In this case, smoking serves as a confounder in the association between alcohol and coronary heart disease. So there are several ways to control confounding, including randomization, restriction, which limits the range of characteristics of patients in the study, matching, stratification, which compares rates within subgroups with otherwise similar probability of the outcome, and multivariable adjustment. And a very different issue from confounding is whether the presence or absence of a variable changes the effect of exposure on disease, called effect modifications. So effect modification is a finding to be reported rather than a bias to be avoided, unlike confounding. So this effect modification can be addressed through stratified analysis, as seen in this example, where the risk of GI complications by aspirin is modified by age and peptic ulcer history. So thus far, we have examined biases and confounding that can threaten the internal validity of research findings. However, since it is not always feasible to conduct randomized controlled trials for all issues, well-designed observational studies that minimize bias and confounding is critically important. So controlling p-force for observational studies at the design phase, including closely mimicking RCTs and using stronger study designs such as cohort studies, utilizing larger sample size, and applying strict inclusion and exclusion criteria, clearly defining zero time, and blinding both the outcome and exposure, and clearly defining validating endpoint, and assuring equal follow-up between groups. At the analysis phase, we may adopt intention to treat analysis, multivariable adjustment, stratification, PS matching or weighting to balance the baseline characteristics, and various sensitivity analysis. So from now on, based on my research experience, I will now present examples where such efforts were made. So this study investigates the effect of aspirin and statins on chemo prevention of HCC in patients with chronic hepatitis B using a nationwide population-based cohort. So the first retrospective cohort study of populations at risk of HCC in patients with suppressed HBV DNA less than 2,000 with antivirals were conducted from a single tertiary care center in Korea, which found that the antiplatelet use was associated with a 56% lower risk of developing HCC. So a nationwide cohort study of patients with chronic hepatitis B or C from the Swedish registries also showed that the low-dose aspirin use was associated with a 31% lower risk of HCC and 27% lower risk of liver-related mortality. A retrospective cohort study of patients with chronic hepatitis B from a single tertiary care center in Korea showed that statin use was significantly associated with a reduced risk of HCC in a dose-dependent manner. Another nationwide cohort study from the Swedish registries claimed that the use of lipophilic statins, but not hydrophilic statins, was associated with a 44% lower risk of HCC compared with non-use. However, the previous studies have some limitations. Aspirin and statins, often administered in combination, may play as a potential confounder or an effect modifier on each other's association with HCC risk. However, no studies have investigated the combined effects of aspirin and statins on HCC risk, which could be addressed by stratification. And because of potential risk of liver toxicity and bleeding, aspirin and statins are less likely to be prescribed for cirrhotic patients who have a higher HCC risk, and more likely to be prescribed for non-cirrhotic patients with chronic hepatitis B under antiviral treatment who have lower HCC risk. However, previous studies include heterogeneous groups of patients regarding cirrhosis and antiviral treatment status, which could be addressed by restriction of the study population. So we used the nationwide claims database, which ensures a nationwide, large, unselected, unbiased cohort. And index date was defined as the first date of diagnosis of CHB, and the primary outcome was incident HCC based on the ICD-10 code. We first applied nested case control study and then applied historical cohort studies for each drug to validate the findings of the nested case control study. So we made significant efforts from the design stage. As I mentioned, we used the nationwide claims database, which ensures nationwide, large, unselected, and unbiased cohort. When we strictly restrict the patients with chronic hepatitis B without antiviral treatment history and without liver cirrhosis. And zero time was defined as the time of diagnosis of CHB, establishing an inception cohort. The exposure and outcome were thoroughly blinded at selecting cases and controls and at cohort assembly, respectively. So we clearly defined the drug exposure referencing previous studies, and for the endpoints, particularly in cases of liver cancer where there is a reimbursement benefit for patients, we utilize highly accurate Korean National Health Insurance Service database. So here are the results. In the nested case control study, we found the statin was associated with a greater HCC risk reduction with an odds ratio of 0.39, compared with aspirin with an odds ratio of 0.89. So those dependent HCC risk reduction was only observed in the aspirin in the statin, but not in aspirin. In 4 groups, according to the aspirin and statin use, the combined use of aspirin and statins was associated with a significantly greater reduction in HCC risk compared with aspirin alone, but not with statin alone. In the historical cohort studies of each drug, aspirin and statin use were both associated with a reduced risk of HCC. Notably, the risk reduction was greater with statin than with aspirin. So this is the most important part. In the drug stratified analysis for each drug, statin use was significantly associated with lower risk of HCC, regardless of aspirin use in aspirin historical cohort. Aspirin did not show such associations in the statin historical cohort, suggesting that the effect of aspirin may have been confounded by the statin use. So we conclude that aspirin and statins were both associated with a reduced risk of HCC in non-cirrhotic treatment-naive patients with CHB. But only statin showed consistent and significant dose-dependent reductions in the risk of HCC. However, moreover, aspirin showed no significant reduction in HCC risk in drug stratified analysis, suggesting that the effect of aspirin may have been compounded by the statin use. So this is the second example. The study may serve as a great example for young investigators, demonstrating how minor differences in the research design can lead to novel findings. So rather than focusing on the clinical implication of this study, I will instead address the research methodology. This study, recently published in God, investigates the association between baseline viral load and on-treatment HCC risk in CHB patients. So due to the revealed HBV cohort study, which significantly contributed to the understanding of the natural history of HBV infection, it was commonly accepted that the risk of HCC increases with increasing HBV DNA levels in untreated non-serotic CHP patients. However, 85% of the patients were HB antigen negative, and due to technological limitations at that time, HBV DNA levels of 5 log were not quantifiable in this cohort. So therefore, it remained unanswered how the association between HBV DNA levels above 5 log and HS risk would be. So to address this question, our research team constructed a historical cohort from a single tertiary care center in Korea, including about 7,000 untreated non-serotic CHP patients, with around 30% being HB antigen positive and more than 5 log quantified HBV DNA. Interestingly, we found another linear but a parabolic association between HBV DNA levels and HS risk. We observed the highest risk around 6 log, with nearly a 4-fold increase in the risk compared to patients with levels exceeding 8 log. So the main research question of this study was that because since the antiviral treatment can suppress this viral replication very rapidly, our key research question was that can the baseline viral load before initiating antiviral therapy still affect the risk of HCC during treatment in patients who have started antiviral therapy? So in previous studies, it was reported that there is no association between HBV DNA at the initiation of antiviral therapy and HCC risk. However, when it closely examined these studies, they treated HBV DNA as a continuous variable. If there still remains a parabolic association between baseline viral load and HS risk, even in patients who started antiviral treatment, similar to untreated patients, HBV DNA should not be treated as a continuous variable. So to address this issue, we constructed a retrospective cohort of approximately 4,700 CHP patients from 5 institutions in Korea who had no cirrhosis and no prior history of antiviral therapy, and serum HBV DNA levels above 2,000 international unit per ml, who started treatment with entecavir or TDF between 2007 and 2019. So we carefully restricted our patient cohort and clearly defined the zero time and endpoint. And this is the most important part. So unlike previous studies, we categorized HBV DNA for patient grouping into low, moderate, and high viral load. So the sole difference between the previous studies and ours lies in whether HBV DNA was evaluated as a continuous variable or categorized as a nominal variable. So in observational cohort studies, both follow-up and treatment are crucial. If follow-up differs between the groups, the result may be biased, and there should be at least 10 outcomes per variable to obtain a reliable estimate. And in this study, the patients were followed up at the interval of 6 months from the index date to HCC incidence, death, liver transplantation, or the last follow-up date. And treatment was continued even after achievement E antigen seroconversion. So here are the results. During a median follow-up of 7.6 years, HCC developed in 193 patients. Interestingly, a non-linear parabolic association between baseline viral load and HCC risk observed in treated patients, similar to untreated patients. The risk of HCC was 3 times higher, around 6 log, compared to levels exceeding 8 log. So these findings were consistently observed in multivariable analysis, IPW analysis, and competing risk analysis to enhance the internal validity of this study. So we tried really hard to control the confounding, including multivariable adjustment. So those variables are the list for multivariable adjustment for the potential confounders in relationship between HBV DNA levels and HCC risk. And also we adopted PS weighting using the same variables in multivariable adjustment. And also the patients were tended to be younger and have less liver fibrosis when HBV DNA levels are high. So we stratified the patients by age or FIFO index, and we found that the effect between the association between HBV DNA levels and HCC risk was consistently observed in a parabolic pattern. But the pattern was more prominent in patients with younger age and less fibrotic burden. which indicates the age and fibrotic burden may play as an effect modifier on these relationships. So previously, it was believed that there was a linear association between HBV levels and HS risk in untreated non-cirrhotic CH patients. However, through this study, we confirmed the presence of a non-linear parabolic association between baseline viral load and HS risk in both untreated and treated patients, albeit some differences in magnitude. So I want to emphasize once again that how a simple difference in research methodology, whether HBV DNA was treated as a continuous variable or nominal variable, did not overlook these new findings, which hopefully may inspire young investigators here. So let's summarize my talk. To ensure confidence in research findings, internal validity is crucial, with controlling for bias, chance, and confounding being highly important. Because we cannot conduct randomized controlled trials for all issues, we have to rely heavily on the well-designed observational studies. In particular, for observational studies, efforts to control bias, chance, and confounding from the study design to the analysis phase are of utmost importance. Thank you very much for your attention. And finally, I would like to promote the Liver Week hosted by the Korean Association for the Study of the Liver, taking place from June 27th to 29th in Seoul this year, Korea. So we kindly request your attendance. Thank you.
Any questions? Terry, are you going to discuss some of the analytic issues like propensity scoring in your talk today, later?
Yes, thank you, Professor Kim. Yes, I'm going to talk a little bit more on propensity scores. So yeah, I think Dr. Choi already gave us a very good introductions about what sorts of biases and we can encounter in observational studies, and how we at least can acknowledge the bias and also find such different ways to minimize the impact of those bias on the reliability on the finding. So particularly, I like the one of the analysis that Dr. Choi just points out is the use of nested case control studies and also the forward cohort studies in analyzing the same issues. So just now, Dr. Choi have studies on comparing statin, aspirin, and the effect together on the outcome, because this kind of study is quite difficult to do, because so as a patient they won't start aspirin and statin at the same time during their follow-up. Maybe they start one first and then the others. So case control study would be a good way to handle such a problem, because you just simply so you look backward from whether you have HCC or not, and then you look backward whether they in their history, in their medical history, they have used statin or aspirin or not, or they have used both. So this can kind of simplify the whole problem, so you don't need to put much care on whether they start one first after the others or the other way around. So, but that also have some caveats, because you take away the time factors. With one start first and one start after. So Dr. Choi's kind of complement this by using cohort studies. So you also consider the duration of the treatment into account. So both of the study design will help to confirm the findings and to add some reliability on the findings. And yeah, I find the talks very inspiring. Thank you, Dr. Choi.
Yeah, thank you so much for your comment, Terry. So I think, to maximize the internal validity or reliability of the study is very important. And to maximize this internal validity from the very first time to start the clinical studies, we have an active discussion with reliable statisticians like Terry. That is the most efficient way to get on reliability of the study. Thank you for your comment.
So if you're not familiar with some of the study design or analytic terms that were used, there are more talks coming up in the second session. So just hang on, and if you have more questions, we'll address them towards the end of the day as well. So with that, I'm going to propose that we take a break. So let's take a 20-minute break and meet again at 10:35. Okay? Thank you. we're moderating the second session too, right? Yeah. Great. 잘하셨습니다.
マイクがこっち、これが合ってます。
これはそうなの。いや、
向こうがってる。
そうか、今、
向こうと。
スイッチはない。だから、現在上がったら入れはる。それは、心配しなくていいと思います。
じゃあもう、ミュートしない。
突然立って、
はい。
マイクのことを気にしない人。だけど。
あ、でもすげえ、めっちゃいいです。
あ、そうですか。
いや、でもこれ同じなんですけど。入ってますね。そう。ちょっとこっち見ると、これで上げると入っちゃう。これで上げてるの？今入ってます。こっちから。設定は変えずに、ズームのミュートが発言ってってますけど、オンライン上になってるけど、ここまでそうですね。ちょいちょいなんか入ってる。周りの人。こうこそ
なんかハウリングしてますけど大丈夫ですか？
USB オーディオがですね、
Thank you for coming back, everybody. While the slides are being uploaded, I don't know if you know, but after the afternoon breakout session, we will select winners from each group, and there will be some gift for the person who present the best. So I don't want to tell you what the gift is. It's a small gift, so don't get stressed, but do your best. Okay. Again, thanks for being here. I'd like to thank APASL for hosting this workshop. Again, this is 20 years since the beginning. So my task is to talk about choosing the right study design, strengths and limitations. Some of the topics have come up already, so I will try to stay on time. So as Professor Choi pointed out, science is study of causality. What causes and what effects, that's the concept. In biomedical research, the term changes to exposure and disease. An example may be hepatitis B causing HCC. So that's pretty clear. So I'm going to ask you a design question. I think you know already this. You want to test the hypothesis that hepatitis B causes hepatocellular carcinoma. Which one is the strongest design? Number one, I'm going to have you raise your hand. Number one, you find at the end, you find 100 patients in your practice with hepatitis B and see who has HCC. That's a study, right? Number two, you identify a group of 1,000 people and test them for hepatitis B, follow them for 10 years and see who develops HCC. That's a study. Number three, you will find 100 patients with hepatitis B, 100 patients without hepatitis B in your practice, and follow them for 10 years and see who develops HCC. Number four, you will find 100 patients with HCC and 100 patients without HCC in your practice and test them for hepatitis B. And number five, you randomize subjects with hepatitis B and inoculate 100 of them with hepatitis B and the other with placebo and follow them for 10 years and see who develops HCC. So which one has the strongest study design to prove the hypothesis? Who says number one? Number two? Number three? Number four? Number five? Yes, you're all unethical, but it is Right. So we talked about this, hepatitis B causing HCC. An observational study would follow people with Hep B and without Hep B and see who develops HCC. And interventional study would be what we just discussed. So this is what I call causality matrix, and there are 4 sort of categories of studies. The top of the food chain is randomized controlled trial because it has you have complete control of the exposure variable. And then, as Professor Choi talked about, internal validity is the strongest in terms of being able to control biases that may be in the study. But not all questions can be answered by RCTs. So there may be non-randomized trials. Close to that, maybe cohort study and case control study maybe at the bottom. And that's the scale of strength of causality going from very high to lower. So which study design should you adopt? It depends on how strong is the hypothesis. If you have a very strong hypothesis, you may want to invest your time and energy to prove that. How common is the disease to study? If you want to do a randomized controlled trial for a very rare disease, you're going to fail. How common is the exposure? Same consideration. What resources are available for this study? So we don't live in a vacuum. We need money to do studies. So if feasible, interventional studies like RCTs generate stronger evidence, but there are advantages and disadvantages, as you can see here, and it's been discussed by Dr. Choi, so I'm going to skip that part. So if you take out the randomized control study at the top, what you have left is cohort and case control study. So I will focus on those for the rest of my talk. Cohort study is the most intuitive observational study design. A group of individuals with known exposure will be followed prospectively, and subsequently the outcome will be determined. So continuing the Hep B HCC example, you will take a population and identify everybody with hepatitis B. So that may involve testing everybody for hepatitis B at the beginning and follow everyone with and without hepatitis B long enough that you will find some cases over time, and you will identify all of them in the cohort, and then you compare the incidence of HCC between people with hepatitis B and without. So that's pretty basic, clear, right? No surprises. So graphically, this is what it looks like. At the beginning of the cohort, you have a population, some with the exposure, some without, and over time, people will develop disease and some will not. And you can actually measure the instance of the disease occurrence. And there are 4 kind of relationships. You can have exposure, no exposure, disease, no disease. And that can be expressed in this 2x2 table, whether you have exposure or whether you have disease. So once you have that, then this is the next step in cohort study. You can actually calculate the instance, and that's instance of disease among the exposed, which is the top row, that the denominator being A plus B, those who are exposed, and people who develop disease A, that would be the numerator. So that's instance in the exposed, and the instance of disease among the unexposed will be the bottom row, same setup, C divided by C plus D. So relative risk or risk ratio is what you get out of a cohort study, and that is simply the ratio between the instances. So the math is pretty simple, but the disease design is not as simple. This is my favorite example. Huai Yang from Taiwan published a New England Journal of Medicine paper more than 20 years ago, a cohort of almost 12,000 individuals from 7 townships in Taiwan, recruited in the early 1990s. They were followed for a median of 7.8 years. And if you look at the paper, they present this 2x2 table that has exposure and disease, and then you can calculate instances and instance ratios. So bottom line, the relative risk, the ratio between instances is 11.7 here, interpreted as hepatitis B, increasing the risk of HCC by about 12 times, right? Straight enough. So math is easy, study conduct is long and complicated. So cohort study gives you the only study design that directly established instance or the absolute risk, that's the A over A plus B. Strong evidence, stronger evidence of causality, not as good as RCT, but as strong as you can be with observational study. You can be very accurate about exposure because you will be testing everybody with hepatitis B, for example, at the beginning, and it allows the study of the relationship between exposure and many diseases. Once you have a cohort in hepatitis B versus not, you can talk about HCC, you can talk about lymphoma, you can talk about other extrahepatic manifestations of hepatitis B. Disadvantages, it is inefficient. You have to have a large cohort for rare disease. Liver cancer, after all, is relatively rare. So you will have to start with a very large cohort. And the importance of sample size was mentioned by Professor Tateishi, and that is so true. It is expensive, it is lengthy, and the studies are limited to exposure data collected at the beginning. So at the beginning, you collect hepatitis B data, but hepatitis C was not even discovered. So you can't ask that question, or you can test the interaction, things like that. So that would be the limitation. So that is a cohort study design, straightforward. So I'm going to transition to case control study now. Next question. You're designing a case control study to determine whether hepatitis B virus causes HCC. What are your controls? Controls are patients with hepatitis B who develop HCC, or patients without hepatitis B who develop HCC, patients without hepatitis B, their controls, or patients who do not develop HCC. Who says number one? Patients with hep B who develop HCC. That's not, doesn't sound like controls, do they? So no one, okay. Who says number two? No one. Number three, patients without hepatitis B. Number four, patients who do not develop HCC. What about the rest? Okay. Number four is the correct answer. So some of you already know this, and others, I'm happy to share this with you. So in contrast to cohort study, which goes from left to right or progress in the direction of time, case control studies are done backwards. So you start with the cases and controls with the disease state, and then go back in time, in concept, whether you have the exposure or not, by testing them backwards. So you get similar 2x2 table at the end of the study. Exposure, yes, no. Disease, yes, no. So corollary of hepatitis B example is again this, whether you have HCC or not, and then you ask whether individuals have hep B or not. And that's the case control study design. The 2x2 table in case control studies are just A, B, C, and D. You don't have the last column because it has no meaning. Unlike cohort study, the total column has no meaning, and instance rates cannot be computed. Does that make sense? Because the sum of disease and no disease, the sum doesn't mean anything. The ratio doesn't mean anything. It's just who you have in your clinic, in your sample. So it does not reflect the instance. So you cannot calculate relative risk as you did. Relative risk was ratio of instances. In case control study, you cannot do that because the last column is meaningless. Instead, you get odds ratios, which is A times D divided by B times C. The meaning of odds ratio is similar to that of relative risk, and that's why case control studies are useful. So an example is this is a Jorge Marrero's study from University of Michigan. 70 patients with HCC identified from a hospital clinic, and 70 patients matching controls without HCC at the same clinic. So that's case control setup. And you're going to determine exposure and that is by asking whether they drink alcohol or not by a questionnaire. So you have disease or not, HCC versus not, and then you have alcohol exposure, yes or no. And then this is the 2-by-2 table. Again, there's no meaning to adding these two numbers because it started from this way. So odds ratios, odds ratio here is this times that divided by this times that, so 3.7. And the interpretation of the data is that heavy alcohol use is associated with 3.7 times the odds of developing HCC. So that sort of speaks to the risk of alcohol associated with hepatocellular carcinoma. So this is Yang's study, took 10 years, 12,000 patients, long time, a lot of money. Marrero, this probably had a fellow, right, going through the chart and then finding who had HCC versus not, and sending survey questions, and then collecting their data. So this probably took less than 6 months and not a lot of money. But you get useful answers like this, and that's the strength of case control study. So cohort study versus case control study, how do they compare? If Dr. Yang was smart and chose to do a case control study, he would pick HCC and controls in 2002, like Marrero did, and then determine their HBsAg status, right? So this is a cohort study data that I shared with you that showed relative risk of 11.7. If they did a case control study and picked 50 cases and 100 controls, if the selection was proportionate to the risk, then the 50 cases would have 37 surface antigen positive individuals and 13 negative. Controls will have 19 and 81 based on this ratio. So if the case control group is representative of the cohort, then you would get this number. The odds ratio from this 2-by-2 table is 11.9. And to me, 11.9 is close enough to 11.7 that they found the truth, that they have the exact same answer with case control study than the cohort study. But the big if here is that you have to have the right numbers in the 2-by-2 table, and that gets back at the bias question of not introducing selection bias or identification bias here to make sure that the 2-by-2 is correct. So the most important point about case control study is a case control study will give the right answer only if selection of cases and controls are random with regard to exposure. I'll let that sink a little bit. So the case controls should be random with respect to exposure. So let me give an example. If Marrero did a study and said, I'm going to collect HCC cases in liver clinic and controls from alcohol addiction clinic, right? Then most of the controls will have exposure alcohol, and random number from the cases will have alcohol exposure. So if you did a study like this and calculate odds ratios, you will get an odds ratio of 0.1. And that says heavy alcohol is associated with low risk of HCC. That would be wrong data, right? So where did that bias came from? And that's because the exposure, which is alcohol, was contaminating the controls. So the selection of case and controls need to be random with regard to the exposure. And in this setup, it is not random because the controls were found in the alcohol clinic, which is obviously enriched with alcohol individuals. Does that make sense? So the cases and controls should come from the same population as you would have picked in a cohort study. So finding the right controls is critical. Getting the right answer from a case control study. So I hope that is clear. This is my last slide. Research is cause-effect relationship. We talked about RCTs having higher validity, but observational studies are often conducted because that's what we can do. Cohort studies are stronger of the observational studies, but it is more difficult to do. And case control studies are easier to do and can get to the right answer, but you have to know what you're doing. So think about the controls and cases. How do you avoid biases in your data collection and do the right thing? And that's where I spend a lot of time thinking about what can screw up the study design and introduce biases. I hope that's helpful. Thank you very much for your attention.
Thank you, Professor Kim, for your very informative and educative lecture. We have 5 minutes for question and answer.
It's okay
Did anyone?
not to have questions. We're running a little bit behind. But any burning questions, I'm happy to answer. I'll be around, so grab me. And that brings me to this point. So in this workshop, we're talking about research methodology for half a day. And how much can you learn? Can you really learn something today and go home and be a world prominent researcher? No, you can't do that. But the purpose of this workshop is we give you some tips. I hope I give you some tips, some ideas that you can utilize in your study. But that's one. And the other is looking at other people who do in a similar circumstance what they do and get some inspiration, what ideas you may have. And then I think the most important thing is that there are senior people in this room that it's good for you to get to know. So I can speak for myself and everybody else, I think, that if you want to connect with us, just come up and say hi and connect by email and things like that. So take advantage of this half day or day to advance your career. I hope that's helpful. Okay, so I'm going to introduce the next speaker, who is Professor Young Izebo. She is coming from Harvard Medical School. She's a chief academic officer for Beth Israel Hospital. She is a physician scientist, and she has been an expert in immunology with regard to various liver disease. So she's going to talk about, do you have the slides up? Managing research team for your research. Thank you.
So good morning. I'd like to express my greatest gratitude to the APASL organizers and to Professor Kim for keeping this workshop going. And I had an opportunity to participate in previous years, and it's really a pleasure to be here today. So it's kind of interesting because I'm not going to talk about science, and I was asked to talk about some of these kind of non-scientific things that we all have to deal with, and then probably we're not getting any lessons or introduction about during medical school or your PhD training. So I'm going to go through and try to bring together here lessons that I learned in sort of leadership roles, and also with what I kind of practiced and experienced the past 20 years since I have my laboratory. None of these have anything to do with the presentation today. So I'm going to start saying that my team, I'm so privileged to work with all these people in my group. And currently, I don't have a huge team, particularly compared to some of the big laboratories that are around this part of the world. But certainly, I work with some senior instructors who have been in the lab and have been postdocs for about 5 years, and now we're transitioning to instructors, some postdoctoral fellows, a visiting scientists, a GI fellow, technicians, a few, and clinical coordinator, because I also have basic science, translational, and clinical studies. I think these are the components that you may want to think about as you build your team. So depending on whether you're in a basic lab where you have potentially a lab manager, a technician, postdocs and graduate students, or you might be in a clinical research when you work with research nurses, research coordinators, and some other people on the clinical side. Then on the clinical side, you may have residents, medical students, and clinical fellows who kind of come and go and participate in your research. In the basic lab, have summer students, visiting scientists who kind of add on. And of course, you deal with your co-investigators and collaborators and consultants. But at the heart of it is you who builds really and keeps this team together. So how to think about this? Well, you know, when you look at yourself and your team and your boss, there is kind of this relationship that's kind of very much integrated and interdependent. And when you think about, when you go to any kind of leadership courses, they're gonna say that, well, you can manage up or manage down, meaning that you interface with those people who are kind of whom you are responsible for, and managing up meaning that how do you present your kind of findings and relationships with your superiors whom you are directly to your boss essentially. But I also want to think about it because many of these labs, particularly if you have smaller labs, they probably are in a unit, in a center, a liver center or something like that. So that's kind of the extended version. You have your division, and all of that is probably in a department and in an entire institution. The reason why it is important because you want to kind of take advantage of all of your external environment, whether it comes to collaborations or some equipment or technologies when you are building your research team, or to patient populations if you are on the clinical side. And this is something to really keep in mind. In fact, the institution could be very important because if you find yourself in an institution that really values what you do and the kind of research that you want to build, it could be a major advantage as opposed to trying to do something in a place where maybe it's not kind of valued and appreciated enough. So these are kind of components of managing your research team that you have to think about, although I think very often as a scientist or a clinical researcher, you kind of focus on the science part and the clinical questions. But there are many resources, and again, you need to be aware of this and in fact take advantage of that. So typically, at least I think in the United States and many other places, we have a research administration team. Then these are the people who help with the kind of submitting a grant application and keeping track of the money that comes in after you receive some funding. Then we have human resources, and these are the group, the institution who helps with hiring and visa and salary determinations. And then, of course, depending on what type of research you do, then you have to interface with the various regulatory boards within the institution, including the animal protocol, the IACUC, that's Institution Animal Safety Protocol Committee, or human subjects protocols for the IRB, and depending on, again, what kind of agents you use, infectious agents has to go through a biosafety committee, like if you did some COVID research. Pharmacy and institutional and research pharmacy in case if you do any kind of interventional drug trials. So these are all components that you need to think about and interface with and know what the rules and the resources are. I wanted to point out the Tech Venture Office, and of course this has potentially different names at each institution, but essentially these are the people who help with any kind of intellectual property, material transfer agreements, if you want to take some reagents from somebody else or transfer mice, and also with patent applications. Particularly, I think if you're at the beginning of your kind of building the lab, it's easy to get kind of entangled in the science and be excited about it, not realizing that actually that could have some intellectual value. So it's always a good idea to bring your new findings to the intellectual property office, because they may help you to advise on how novel is this really in terms of business development. And if you're lucky, then you may file a patent that a few years later brings big amount of money to you or to your institution. So when it comes to managing your team, I think the basic principles are pretty much the same in the laboratory than anywhere else when it comes to managing a team. You want to be firm and straightforward and fair, having the same expectations and kind of standards for everyone in the team, so people don't feel like not treated equally. I think communication is really a very important component in there, and setting clear expectations. I also think it's important to listen to your team members, because the feedback that they give may help you to better kind of communicate or better kind of help their needs. And I also find that particularly in research, meeting as a group is very important because everyone can hear the presentations of others and they kind of gauge themselves based on the sort of expectations and the quality that others bring in. And it's important to recognize when somebody is doing a job and praise them because positive reinforcement is just kind of part of human nature. And maybe a little bit later on, we can talk about how to handle it in another way. If somebody didn't perform very well, typically you wouldn't want to do that necessarily in front of the entire group, but it's perfectly fine to give a one-on-one kind of feedback to individuals who may have some problems. So how can you help others to manage up to you, so to get some feedback? Well, I think having an open door policy, which I think in laboratories is pretty natural, but to be accessible to people if they wanted to tell you something. And then I think another component in research, which is really critical, is about kind of mistakes. So as you very well know, particularly in the current era with the technologies and plagiarism programs and very fine imaging kind of analysis that one can do on previously published or currently published results, the scientific conduct and misconduct issues are coming up. And this is a very, very kind of serious and important area for everyone. So as a lab manager and somebody who is running a lab, this is something that we have to be very careful about. So at the same time, you want to create a culture when if somebody made a mistake, they feel comfortable telling you and not to put too much pressure on the lab, on the individuals who they may feel that if they did something wrong, then it's going to have a negative consequence. So I think that that's very important and kind of acknowledging that, in fact, sometimes things don't go well, or if there is a result that you cannot really interpret, that's okay. We may just have to look at it in a different way or repeat it is very important. As you go on to grow into a role of managing your team, particularly if you come from being a postdoc and junior faculty with a very small group, then it's easy to kind of wanting to do everything yourself. But I think at a certain point you have to develop the comfort level how to delegate certain things to others in the lab because you're not going to be able to do it all as time goes on. So sometimes you may want to step back and ask yourself that how are you managing your team? So do people who report to you trust and respect you? Do you trust them and respect them? And that's kind of, again, I think it's a very basic element of being particularly in a research laboratory, to develop the integrity and honesty component. What do you do directly to help them be successful? And do you take that, sometimes some information comes from your leadership, from above at the institution, and if something is kind of not necessarily positive, how do you present it to people in the lab in a way that they don't lose kind of interest and energy? And how are you a good mentor? Are you a good mentor to your team members? I think those are kind of important components. Now, when it comes to running your lab, very often it's way more than just the science. And in fact, some of us may feel that, well, you really don't want to burden and deal with some of these other elements, but the fact is that most likely you'll have to. So finances is one that is very often it's just simple math, which may not be that simple, right? Because you want to know where your money is coming from, how much money you have, and then really deciding whether you're going to have enough resources to actually maybe take on one more person, or how long is somebody going to stay. If a postdoc kind of goes on and decides to leave all of a sudden, how do you replace them? And then, of course, when you come to finances, you need to think about what type of experiments to do. Sometimes scientifically, it sounds exciting to do that single cell, whatever, omics, but then it's going to cost you, the other day they brought me a $90,000 estimate, and I'm going like, really? So you have to kind of put the reality and the scientific rigor and the new technologies kind of in a balance, which is really not easy very often. So for this reason, you have to plan your project and grants and really kind of be at the forefront and think about how is this going to look like a year or two from now, because you don't want to have major gaps in your team. So this is where it comes to like negotiations sometimes with your institution and planning out your grants. That could be very important. So I'm going to get into some kind of details here to maybe give you some thoughts that, now you are at the point that you really want to build your team and hire a postdoc or a student. So how do you go about it? Well, I think it's important to outline the project and figure out what is really the kind of niche that you need for. And then make sure that you have salary for supporting this individual, because you don't want to bring somebody on to find out that 9 months later you don't have enough money for it. And then, of course, some technicalities in terms of working out with human resources, how to go about it. Each institution has various rules. You have to write a job description, you have to write an advertisement, and of course the advertisement has to be interesting enough because there are so many ways to post a job. And then there you have to be kind of creative to make it very exciting, so some people actually would want to apply for it. And of course, going to conferences and knowing some people who potentially are candidates is the best way to go about it. So once you collected the resumes, then the question is how are you going to make decisions? I personally find that involving people who are key in my laboratory now is very important, because at the end, they're going to work together in the lab, and you want to create a team that actually works well together. So typically we interview the top 2-3 applicants, ask them to give a talk, and then they talk to everyone in the lab before we come to the final sort of decision. And we're looking for obviously primarily the same thing: creativity, willingness to learn, and potentially bringing new methods into the lab, passion for research. And then of course you want to collect references on these people. And I personally find that talking to a previous supervisor is very valuable. Not just getting a letter. And then at the end, of course, you want to make an offer, and hopefully they're going to be happy to come to your lab. Now, once they arrive, it's important to actually give them the kind of lay of the land and help them to land in the position in a very effective way, because it really shortens their kind of time when they cannot do really good experiments. So onboarding is important. And I think setting expectations with a very clear conversation at the very beginning is important. So tell them that you're going to have 1 or 2 projects, you're open to potentially their ideas, and but then agree what is going to be the commonly agreed project or projects on. Sometimes it's useful to talk about the kind of very basics, that what time are you expecting people to be in the lab and how many hours to work. It's very important to think also about the scientific rigor and have an open conversation about how to use the data, where to put your data. Can you put it on your personal computer or just keep it in the lab, and whom to share the data with. And talk about expectations about confidentiality and potentially even about productivity. Kind of thinking about, well, this project may lead to a publication maybe in a year, the other one might be faster, just to kind of have some general guidelines. And for this reason, I think it's good to have periodic evaluations, not necessarily just to talk about the results that people may bring you, but really kind of step back and say that, well, we talked about these results for the last 6 months, and where are we now in terms of building a manuscript or a project. So basics of supervising are the basics for everywhere in the laboratory too. So as a principal investigator, you are responsible for all aspects of the research and all personnel in your lab. So for that reason, it's important to set your general expectations and share it with everyone, because that way they know and there is no kind of misunderstanding. And also, I think it's important that you realize that you are the one who sets the kind of general tone for the lab. So if you want to have collaborations, you have to kind of really tell people that, what I say to my lab is that, my lab is not that big, and I expect everyone to collaborate. And if they find something new or a new method, I want everyone else to know, so we don't have to kind of reinvent the wheel twice, because it just costs more money for me. The same thing about sharing reagents between people. So these are kind of very basic things, but it's important to really actually tell people, because not everyone comes from the same kind of mindset when they come to your lab. Peer pressure is an interesting thing. People like to have their own niche, but at the same time, I think it's good to cross-validate certain findings and do it in a way that people don't feel offended by that. And for this reason, I think discussing expectations in the lab meetings with the entire team is important. So when you do your supervision, there are multiple ways to do that. either very directly or indirectly. So obviously lab meeting and presentations are a good way of seeing where people stand. Individual meetings are very important. I personally try to meet every week with each kind of postdocs and lead person in the lab. But sometimes we have research project-based team meetings because it could be that several people are working on something together. And then it, of course, becomes that, how much do you really want to have the data, which is kind of the results section of a manuscript versus really seeing the primary data that is behind that. And that is something that you have to keep in mind and do either regular or periodic spot checking. Delegating the day-to-day supervision to somebody who is knowledgeable in the lab is a good idea to a certain point. And then give an opportunity for the postdoc and students both to supervising and mentoring, but also they can supervise students, which is a good opportunity for them to learn how to kind of go about all of this. So when it comes to supervision, I think feedback is very important, but sometimes it's difficult because certainly shouldn't be the 30-second evaluation. It has to be something that is based on facts. And individual meetings are really useful for this. And if there is any kind of improvement plan or weakness in anyone, then you want to follow up on that. Periodic structured evaluations, such as annual evaluations, are kind of difficult to do or have to be disciplined about it, but they are very useful because it really is an opportunity to set the stage and find out what is really the goal of the individual who works in your lab and what do you envision for them to be, which may or may not be exactly aligned. And for this reason, I think it's important to understand the short and long-term career goals of each member of your team. And very often I also ask at those annual meetings, or even more often, that is there anything I can do differently and better to support them? Because your style may have to be different depending on the personalities of the individuals in your lab. Now, we always hope that we have colleagues who are very easy to work with, but reality is that you just can't quite predict. So, there are some problems, and how do you deal with that? Because that's, again, not something that they teach you in any of the schools that you go in research or in medicine. So I think a good thing to remember that identifying and addressing problems in early stages is always better than kind of letting them go and not to realize, even if you realize kind of in the back of your head. They rarely go away on their own. And sometimes if you don't feel that you can handle it on your own, or actually very often it's not a bad idea to get human resources involved, so they would know about it and they can advise how to do that. Very often, if there is some kind of questions that are controversial, it's good to have a third person in the room when you have the discussions, and that's something that human resources can actually provide. So what are those issues? So potentially, could be personality collisions in the lab, that just two people are not don't get along, and it creates kind of a friction, and everyone else around in the lab may feel uncomfortable about it, and that's not a good thing to maintain in the long run. Sometimes there is rivalry between individuals. In fact, I have to always think about it, that it could be that some people actually have some underlying kind of disease that causes them to behave in a strange way. And then, of course, recognizing, which hopefully doesn't happen, sexual misconduct can happen. Often, there are a lot of hormones in the lab, and things happen. And then, of course, scientific sort of issues that are even more serious. So I think the important thing is that to think, to get a sense for it and try to kind of address these things early on. We all know that being in an academic institution is a little bit of an emotional and career kind of roller coaster, right? Things sometimes go very well, and then the next day could be like not that good at all. And I think developing and helping your team to develop some resilience, to really get over the kind of downs, is very important. And sometimes you may need to reorganize, restart, reimagine, and kind of introduce a little more energy to really get over those humps. It's interesting because if you read the literature, that resilience is an ability to grow and thrive even in the face of challenges and bounce back from adversity. And evidently, this is something that could be learned. So it could be very different for every individual, but you have to recognize that as a supervisor and a manager, you need to help your people kind of get over these kind of difficult times. And sometimes it could be related to overworking. So if there is any burnout, being overworked and kind of not necessarily finding the upside can happen to people. And that sort of leads into a work-life balance that, again, is a very interesting definition, because a work-life balance doesn't necessarily mean that you have to spend the same amount of time outside of the work than at work. It's more of a concept that what makes people feel kind of energized and what leads to their accomplishments or their goals. And at the same time, you don't want to let them kind of be overworked and burnt out. So work-life interface is very often bidirectional. For instance, work can interfere with private life and other way around. But it really comes from the satisfaction that the work can provide as a fuel for future progress and for the progress of your team. So I think in terms of success, as your team, I think it can come in many forms, whether it's the next manuscript that is accepted, or going to a conference and having multiple oral presentations, or getting the next grant, or getting a promotion. But it could be different for everyone, and it's okay to actually verbalize what is the next goal for your entire team to really bring them together. But at the same time, I think as managers and leaders, we also have to realize that our team members may define success in a different way that we identified or we thought for them. And kind of talking about what are these expectations and what is a success with each of the individual is very important. So with this, I think I'm just going to stop and really thank you for being here, and happy to answer any questions. And good luck with your managing your team.
I thank you, Dr. Sabo, for your very, constructive and informative, and it's quite a, good experience for me. Thank you. Anyone have a question? Yes.
I have a question, and I would like to study abroad. And the next week, I will have a meeting with professor at the laboratory where I want to work. And then, what is the most important thing to consider when you hire the postdoc? And please give me some advice.
So, and you are going somewhere else, right?
Yeah, I hope so.
So I think it is important to get to know the entire or key people in the laboratory. Depending on how big is the group of this professor whom we are going to, it's important to feel comfortable with that professor. Mm-hmm. But I think it's also important to get to know who else is in the laboratory, and you can ask that from the professor, or you can have actually individual meetings with those people who are in the lab. And I think it's good because you can ask questions from those individuals that why did they go there, how they feel being supported, and what is the culture and the kind of chemistry of the lab. I think that is important. And of course, you want to ask to clarify some very basic things that, how much is your salary, how long are you going for, and those kind of basic things. But it's important also to find out that, what is their style, do they have lab meetings? How often are they going to meet with you? Because not everyone meets with their lab members every week. There are some people who meet like just once a month or every 2 months, or want you to send emails and not necessarily talk to you. So it have to figure out what fits your style the best with somebody else.
Thank you.
Thank you. Okay.
If I can add something quick about that, I think people think about like 3 things. One is this person smart? Can this person do the work? And the separate question is, does this person have the motor to be successful. And by motor, you mean you have the energy and the resilience and, get things done, organization. And the third person is this person crazy? There are a certain percentage of the population has psychopathic or sociopathic characteristics, and they're amongst us. So, and that's when the HR issue becomes. So you need to portray all these characteristics that you can do the work, you're very interested in doing this, and look at my CV. I've accomplished all these things. So that's one on the mentor side. On the mentee side, I think it's super important whether you want to be in the mix. How good the team is and how good the mentor is. One of the things that I advise people is look at the mentor's CV, and if the senior person has a bunch of first author papers, that is probably not a good sign, right? You want to be the first author and the mentor to be a corresponding author someplace. But if that person is always the first author of all the work that comes out of the lab, you probably don't want to be in that lab. But that's all I will say.
That's all very good. Thank you. Okay.
Thank you.
Happy to talk after.
So we're going to move on to the next speaker. I'd like to introduce Dr. Mochizuki. He is currently the director of Genome Analysis Department in Yamanashi Central Hospital. He used to be a GI clinician. I'm not sure he's currently a GI clinician, but his career as a physician extremely, absolutely changed when Dr. Omata moved to Yamanashi Central Hospital, where he developed a large sequencing center. He is head of the genomic analysis. He started to learn our statistics after Dr. Omata moved to the hospital. And also, he is now currently involved in a project of APASL to collect the data of HCC patients. He again learned RedCap, open source platform for electronic data capture, and he by himself learned a lot and developed the entire the system. Today he's going to talk about the beginner's guide for RedCap. I think I trust that everyone in this in this room can learn how to develop the RedCap, hopefully. Thank you.
Thank you, Dr. Tateishi. I'm with Yamanashi Central Hospital, Genome Analysis Center and Gastroenterology. And I'm the data manager of AHOC. AHOC stands for APASL Hepatology Oncology Consortium. I'd like to say a great pleasure and honor to speak here today. Today, I'm going to talk about RedCap system using AHOC study. I have nothing to declare. In this workshop, I know the importance of statistics, but no data, I think no data, no statistics. I'm going to start by talking about introduction of RedCap. RedCap is a short for RedCap Research Electric Data Capture. It's an electric data capture system using the Internet Web System. Vanderbilt University developed it based on an NIH grant. And 1 month ago, 756 institutions in 156 countries and 2.1 million projects used it. RedCap is a revolutionary clinical research support tool that is becoming a global standard in academic medical research. The development concept of RedCap is as follows. Web-based secure system, easy to set up. We can customize our database and survey forms. Support a wide variety of output formats, SAS, R, SPSS, and other text format. REDCap is a simple configuration. It consists of common application for the internet. A database system uses PHP and relational database SQL. However, various security measures are in place. HIPAA 21 CFR Part 11 and FISMA compliance make REDCap a secure and robust system. A strong support can be obtained from REDCap users. First is REDCap Consortium. REDCap Consortium is organized in each country. Consortium members contribute their expire and assistance to each other free for charge. Today I have cooperation of Japan REDCap Consortium. Next is the REDCap community. REDCap community is an online platform for software downloads, extensive technical documentation, a question-answer form, and more. The source code is provided free of charge to install, but for security protection, each institution must have a license agreement with Vanderbilt University. Construction, operation, and maintenance of the server of installation must be performed by institution. Work by companies and non-employees is prohibited. Here's a summary of the first. REDCap also have a variety of other features necessary for critical research. Along with these many functions, easy to handle and support variety of clinical trials and large-scale studies, REDCap is also widely used because it is significantly reduce outsourcing cost, reduce database creation time, and can be used by non-IT professionals like me. Next are the construction steps. As I mentioned previously, each institution must have a contract with Vanderbilt University and then build its system. Once a contract is completed, an unlimited number of projects can be carried out at that institution. REDCap is a research infrastructure. The researcher will develop a research protocol and the data collection methods necessary for the study. These are several steps building REDCap. The success of study depends on the database definition. REDCap only built upon this definition. I'll talk about specific procedure in the AHOC study in the next slide. This is a part of actual AHOC database structure in use. Height is entered as a number to avoid input mistakes and error of display. The range of 50 centimeters and 220 centimeters is exceeded. Weight is in the same way. Display or calculated BMI if height and weight are entered. Similarly, a performance status is stored in the database with PS0 as 0 and PS1 as 1. I also thought about the branch logic, where if you select sorafenib for treatment, when TKI choice equal 1, the hidden sorafenib treatment date will show up. We decided on 140 such items. The EDC is created on such screen according to the definition of the database. Input type and checkbox, screen display labels, list of selections, variable name. These can be easily set up on this screen. Automatic calculations and other functions can be entered in the same way. Finally, this input screen was completed, and many researchers entered their data. Data export supports a wide variety of output formats for SAS, RS, PSS, and others. However, the only data obtained from their own institutions. All data are authorized for use by the data manager. Only data from your institution can be downloaded according to the data access group setting. It is important to set up a data access group called DAG. To ensure data security, as in this figure, Dr. X and Dr. Y with University A can see and modify each other's data, but not the data of Dr. Z with Hospital B. Moreover, the audit function records all data access to see who made, who changed to the database. One of the features of REDCap is the use of dashboard, that you can see the data status in real time. Please look at a snapshot of database dashboard from a few days ago. You will see that number of registrations by countries and institution, etiology of liver disease, child pew classification. Local regional therapies, and anyone registered in AHOC, REDCap, can check it. We can create a dashboard with simple script like this. The figure shows the number of registered cases and IRB-approved institutions to date. By last week, 17 institutions had IRB approval and were enrolling patients. About 350 cases have been registered in the first year since the start of the AHOC study. For example, this graph gives a recent trend in the use of various new drugs. Starting with sorafenib, we believe that by analyzing these various ways, including different countries, background, and treatment method, we can improve the prognosis of refractory HCC. Here is a list of institutions currently participating in the AHOC study. A session including the result of this analysis will be held during the Friday afternoon on day 3 of APASL 2024 Kyoto. Please join us. I hope that many critical questions will be answered using secure and useful tools like REDCap. Thank you for your attention. ありがとうございました。
Thank you, Dr. Mochizuki, for your nice lecture. Anyone have a question?
Thank you for your lecture. My name is Asaka Nogami from Yokohama in Japan. I've never heard of REDCap, and I think it's very important and inclusive. But I found that my institution is not included in this AHOC and probably not joining REDCap. Do I need to ask, if I want to use REDCap, do I need to ask my institution to join, if we can join or not? Because you told me that we cannot use these databases by individual.
Yes. If you hope to join our AHOC study, please contact the APASL Secretariat Tokyo.
Thank you.
It's okay. And after that, I'll send IRB approval or protocol, and please process the IRB. なんじゃ?
Then if our institutions approve, then I will be able to use the AHOC data as well. Oh, that's nice. Thank you.
Thank you.
I think that's an important point, that your institution doesn't need to be a member of the REDCap community. If you join a study in which REDCap is used, they give you access to the database. Then you can enroll, you can add data using REDCap, right?
Yes.
The other question that may be helpful is, a lot of people use Excel or spreadsheet for data collection, which is fraught with problems that I won't go into, but I think it's an important point that if you have data in different format, that can also be imported into REDCap, right? That's correct, right? If you have data in Excel, for example, and if you have access to REDCap software, then you can import your Excel data into REDCap, transform the data format, and use
that's right.
going forward.
A very easy script can change the protocols, Excel or other text data to REDCap, and REDCap to the Excel or text data.
So, yeah. Actually, you can upload the data to the system. Thank you. Thank you very much. So I'd like to move on to the next topic. If you have any questions, please, ask him personally. So the last lecture will be presented by Dr. Terry Chak-Fan Yip. It's my great pleasure to introduce him. He is a very talented biostatistician from Chinese University of Hong Kong. He was involved in, and also currently involved in the large, studies, clinical studies. He will talk about the performing statistical analysis. That might be very helpful to you regarding to understand what the statistical program or statistical method means. Thank you.
Thank you, Professor Tateishi, for the very kind introductions, and I'm also very grateful for the opportunity to talk about performing statistical analysis in this AASLD APASL workshop. Thank you very much for the invitations. So, what do you think statistics is about? Maybe you recall once upon a time you attend a statistics class, and this is what usually the student may do during the statistics class. And maybe you're struggling with hypothesis testing, so you're thinking of whether you should do t-test or Mann-Whitney, chi-square, etc. Or maybe you are struggling with data modeling, so you know the different kinds of regression, and maybe your supervisor advised you to go for machine learning, AI stuff, and learn more and more, and there's 10, 20, 30, if not more algorithms outside, and you have to learn that one by one, so you may find it difficult. Or maybe, at last, maybe you only care about the p-values and whether the magic's 0.05 is met or not in your final paper. So yeah, maybe every aspect means something to you. So to me, the major objectives for performing statistical analysis would be three major objectives. The first one is descriptive statistics. So after you collecting a sample, so you would like to summarize it using graphs or some numerical summaries. Of course, you know about mean, standard deviation stuff. And you also want to take the chance to explore a little bit on your data set to see whether you find any preliminary relationships between variables, for example, in the data, so that can drive you to the next step. So what you want to ask, or you already have the question in your mind, so whether the data set is sufficient to answer your questions. Second is called statistical inference. So of course, when we do a study, we have a target population, and the best scenario is we can screen everyone, collect data for everyone, but it is simply not possible if your target population is very large. So probably what we do is to collect samples. So just now, Dr. Choi also mentioned about this. We're collecting a sample, so make sure that we do not have like any selection bias regarding the samples. And after you collect the sample, you can understand the population, or in statistics, we call it infer. So how we can use samples to infer the target populations. And the common tools that we use here is hypothesis testing or regression analysis. And finally, we also want to predict the future, of course. So after you're collecting samples, you want to know more about what will be the future of the whole population, how will be the risk of certain disease in next 10 years, and can we estimate that? And the tools that we use here will be also regression, or maybe some like machine learning AI stuffs. So here's the common workflow. If you are performing clinical studies, in most cases, it's not possible to screen the entire population, so you take a sample. For example, if my target population is a patient with chronic hepatitis B on the right-hand side, so maybe a good or a possible sample would be patient with chronic hepatitis B in your own hospitals, so that you can examine the data one by one, so in your hospitals to understand more about the whole target population. Then the samples can be described using descriptive statistics, for example, mean age, the percentage of females, the median ALT, etc. And then you can choose whether you want to do inference, you want to understand the population, for example, the association with, of some risk factor with the clinical outcomes like XCC, or you want to do prediction. So you want to predict the future risk of, for example, XCC in the patients, in the target population. Or maybe you can do both, of course, using the same sample. You can do both inference and prediction. So talk about descriptive statistics, so that include graphs and also numerical summaries, mean, standard deviation, etc. So the first part of my talk will focus on descriptive statistics. So why it is important? Because it helps us to understand the trend and outlier for data exploration. And of course, it's also helped us to communicate complex idea with your target audience. For example, if we do like scatter plot to understand the relationship between two continuous variables, X and Y, so immediately by the scatter plot, you can appreciate the trend. So it is the FH trend about like when X increase, Y is also increasing. So this is the FH trend. It's often a measure of interest when you do research, because you want to know what is the general trend in your target population. But sometimes there is outliers. So some data points that do not obey the general trend. But outlier is also very important, because sometimes maybe outlier is your research interest indeed, because you want to know why these data points do not obey with the FH trend. So I would say both trend and outlier are interesting. So by using plots, so you can easily locate some possible relationship that may appear in your samples, and you may want to investigate it further. Of course, if you list the numbers like in spreadsheet, it will be pretty hard for you to locate an outlier. So that's why we should do plots. So actually, descriptive statistics is about choosing the right graphs and choosing the right numerical summaries for your data. So first of all, you have to understand some simple concept called the data types. So the choice of the graphs and numerical summary depends on the data types. So we have two major types of data types, including qualitative and quantitative data. So qualitative data, we also call it categorical data, which can be two major types inside, including nominal data and ordinal data. For nominal data, it is discrete categories. So just now, Professor Mochizuki also mentioned about that. So like gender, race, or alcohol use, so non-drinker, drinker, or non-drinker, ever drinker, ex-drinker, etc. So it's nominal. So every category is distinctive. For ordinal data is continuous. So although it also consists of category, the category are continuous. For example, the level of agreement, let's say strongly disagree, disagree, neutral, agree, and strongly agree. There is an order, there is a direction in the categories. So it makes its difference from nominal data. For quantitative data, or sometimes we call it numeric data, there are also two subtypes, including discrete and continuous data. For discrete data, it can be counted by your fingers. For example, the numbers of admission for patient in the previous years, 1, 2, 3, 4, 5, etc. For continuous data, of course, ALT levels, BMI, such things, so they are continuous. So to visualize qualitative data, of course, I don't need to introduce you to bar chart. I think all of you all know about that. But just to show you here that the bar chart can also present ordinal data. For example, on the left-hand side, the x-axis is the weight reduction. So we can, before we separate them into subgroup, you can appreciate that weight reduction is actually a continuous variable, right? So because it can be 1, 2, 3, 4, 5, 6%, right? But after we subgroup it into different category, it changed from continuous data to an ordinal data. So actually, for data types, it's not fixed. So it depends on how you interpret the data and how you subgroup the data. You can change a continuous data to a categorical data if you want. So for bar chart, this is a good chart to document the change in different categories, be it ordinal or nominal. But here I give you a tips in order to produce good plots is to increase the data ink ratio. So you can appreciate there is 2 bar charts on the screen. So the left-hand side is more beautiful, of course, because there's some design, some icons. The font type is more elegant somehow. So if you are doing a poster or an advertisement, of course, the left-hand side bar chart is better, right? It's not more pretty. But in terms of academic research, actually we are chasing or we are pursuing a higher data ink ratio, which is the right-hand side one. So what is the good things about the right-hand side bar chart? It's effective. So it is very concise, and you don't need to, for example, read through the y-axis to know about the height of the bar. Instead, you can immediately look at the top of the bar and you'll know the number immediately. So the convey of message is very fast in terms of at the right-hand side of the bar chart. So usually in academic research, we look for precise, concise bar chart, so very fast. And you don't need to interpret what is the icons about why there is a printer and also why there is a gradual change in color. That's not meaningful in terms of conveying the message. So be simple, less is more. So of course, maps and also pie chart is also very useful in visualizing qualitative data. So comparing pie chart and bar chart, you will see in general, we see more bar chart than pie chart in academic research. It's because pie chart is big, is occupy a lot of space, and also people perceiving for the comparison of big and small, usually people perceiving height better than area. So that's why bar chart is considered to having a higher data ink ratio than pie chart. So that's why we seldom use pie chart in academic research. But of course, if you are using it with something else like the map, I think it is still very useful as long as you do not have a lot of category. For example, there's only 2 categories. So the PNP LA3G risk ALICE. So yes or no. So only 2 categories, easier to document by pie chart. But imagine if you have 5 or 7 categories, it's pretty hard to present it by a pie chart because they will have a lot of sectors in the pie chart, which may not be good for the presentation. And also heat maps is also another very famous way to present the data. So because you can show the intensity, for example, the gene expression, transcription, expression upregulated or downregulated, you can simply present a large amount of data using a small diagram. So another tips here is about the usage of colors in graphs. So basically, for choosing colors, there are 3 kinds of color maps called diverging color maps, sequential, and qualitative color maps. And here are some links that helps you to choose the correct color that suit the best of your cases. So I will introduce the color map in the next slides. So some common examples for good and bad use of colors. For example, to present nominal data, we will prefer to use qualitative color. It is because we want to show each of the category as distinct as possible. So we use color that distinct from each other as the color map. But if you use sequential, because the color look quite similar, it will not help to convey the message, leading to a lower data ink ratio. For 2-side ordinal data, a natural choice will be a diverging color. So you can show the 2 extremes easily by using the color. And of course, for 1-side ordinal data, the sequential color map from the lighter color to a darker color will be a natural choice of increasing intensity of something. For example, the prevalence of certain disease like measles. Just Professor Grace also showed us a similar map in United States. So using the sequential color map would be helpful, but you imagine if you use a qualitative color map, the first thing that you need to do is to read the legend to see whether brown color means a higher preference or a blue color means a higher preference. It's difficult or less easy for you to understand the message when compared to the sequential color map, of course. So, and then for quantitative data, like continuous or discrete quantitative data, so there are a lot of choice of the plots, but I will not talk about all of them today, and I will focus on scatter plot, box plot, Bowling plot, and histogram. Histogram is important because it approximates the shape, or in statistics, we call it distribution of quantitative data. So in statistics, so there are, of course, different well-known distribution, like normal distribution you have encountered already. There's also other well-known shapes like exponential, logistic, etc. But of course, normal distribution is the one that we use the most. And it is simple to display normal distribution because we only need two numbers, mean and standard deviation. Why? It is because mean can denote the center of the distributions, and SD, the standard deviation, can denote the spread of the distribution. Because it's symmetric, so the left-hand side standard deviation or the right-hand side standard deviation will be the same. So that's why we only need two numbers, mean and standard deviation, to describe a normal distribution. So that's why when you present some like mean age or in your data set, you usually use mean and standard deviation to present it, because that can already summarize a normal distribution. But box plot is something else that we can present, because we know that sometimes the distribution may not be normally distributed. At that time, we cannot use two numbers, mean and standard deviation, and we have to use more. For example, medians and the IQR. And box plot is also very useful to compare like different categories and the distribution of certain variables in different discrete categories. So why we need box plot is that because we know that some distribution is not normal, and median and IQR would be a better choice to present non-normal distribution. Why? It's because the shape will be looks like this if the sample is non-normal. So you can no longer use mean and standard deviation alone to describe this distribution, because left-hand side, the spread, and right-hand side, the spread is different, right? So you cannot use single number to describe both left and right. So you have to do at least three numbers to describe middle, left spread, and right spread. So that's why we have Q1, 2, 3, and median and IQR denotes these three numbers. So these are some common non-normal distribution like right skew or left skew, whether you have to use median and IQR to describe the distribution. And of course, we have some other interesting non-normal distribution, for example, the bimodal distribution, where you have two peaks in your data, or something called uniform distribution, that every bars have a similar height. So the occurrence of each of the outcomes is around the same. So we call it uniform distribution. And at that time, box plot may not help us to distinguish bimodal or uniform distribution, because the median is at the middle, and the Q1 and the Q3, the spread is the same on the left or right, because they are almost symmetric in these two distributions. That's why we need something called the Bowling plot, which is box plot plus histogram. So you can see in Bowling plot, there's a box plot at the middle, and on the left-hand side and right-hand side of the body, they have the histogram that shows the distribution to show the whole distribution of the data, so that it can distinguish different kinds of non-normal distribution. Scatter plot is also very useful in terms of showing correlation. So in statistics, we have something called correlation coefficients. So it is a statistics to measure the strength of relationship between two quantitative variables, and this value range between -1 to +1. If this is closer to +1, that denotes a positive correlation. One is increasing, another also increase. If this is closer to -1, it's negative correlation. So if one variable is increasing, another one is decreasing. So the strength, the size, the magnitude of the correlation coefficient would denote, would indicate the size of the correlation between the two variables, continuous variables. And scatter plot is a good plot to show whether a correlation exists between two continuous variables. And in terms of like big data analysis, scatter plot is also helpful for something called clustering analysis, because we know that sometimes the data are scattered into distinct groups, for example, clusters. So within each of the cluster, that consists of like more homogeneous data that look similar to each other. So, in terms of like big data analysis, so maybe we have like 1 million or tens of millions of data points. It's very hard to analyze all the things at once, right? So instead, what we can do is do clustering analysis so that we can separate them into different subgroups, and then we analyze each of the subgroups separately. So that makes the analysis possible. So scatter plot will be useful in such a situation to see whether clusters can be identified and whether you can perform further analysis in each of the subgroups separately, so to help to facilitate the analysis. So this is my next part of my presentation about like what we usually face and doing clinical study. And here I use an retrospective cohort study as an example. So this is what a data set would look like. So just now, Professor Mochizuki also showed us a data set which looks similar. So usually we have a unique identifier to identify each of the, for example, patients. And we have something called the covariates, factors, variables, or attributes that denote each of the aspects of the patients, for example, the age, gender, presence of cirrhosis, for example. So here is a data set we try to examine the fracture risk in patients with chronic hepatitis B, comparing like treated patient and untreated patients. And finally, as a cohort study, patients were followed up longitudinally so that the fracture may occur at any time during follow-up. So that's why we have to use 2 columns to denote the outcome, including whether fracture occur at the end and when the fracture occurs, so in terms of follow-up duration, in terms of years. But you also notice that in retrospective study, we usually have the problems of missing data, so that's why there are some question marks in the data set. So a simple way to deal with all these kind of missing data is to exclude all of them. So you just exclude any rows that with any question marks in it. But this causes a problem on selection bias, as mentioned by Dr. Choi. The selection bias here is that those patients with missing data may be different from those patients with available data. For example, maybe some like ALT measurement is missing in some of the patients. Those patients may be too ill so that they cannot come back for a blood test, or maybe they are healthy so they don't bother to come back to take the blood. So those patients with missing data can represent other population that you want to analyze, but you cannot analyze. So if you simply exclude them, the remaining patient in the sample may not represent your target population anymore, or it will cause something called selection bias. And of course, because the reduced sample size, after exclusion, it also affects the statistical power for you to detect any like difference in parameters or difference in outcomes in different groups. So that's why we have to perform missing data analysis. So plots can also help us in such a situation to see whether the missing data occur more frequently in certain subgroups of patients, and you have to think of that, whether this is a systematic error, so whether data inputs is problem, or whether actually this reflects the situation that certain patients, maybe they are more healthy, so they won't bother to take certain tests. So you have to acknowledge this kind of like limitation in your studies. So confounding, so I don't need to spend more time because Dr. Choi already explained it very well to us. So of course, we know that in a cohort study, or especially in retrospective one, we have a lot of confounding factors. For example, I want to compare patient with treatment and with patient without treatment on the risk of fracture. But we know that in hepatitis B, so for those patients who were treated, they're usually older than patients who were not treated. So age here is obviously a confounding factor because older age also correlated with fracture. So that's why we have to do something called multivariable adjustment to handle confounding. So here is a simple like cost regression, hazard ratio less than 1 means a like protective effect. Higher level of covariate will be fewer outcome, and the other way around. So here I just do a simple multivariable analysis. So age, gender, and the use of antiviral treatment on the risk of fracture in the future. So we can see like older age is more fracture, and female gender is associated with more fracture, and also the use of antiviral treatment is associated with more fracture on univariate analysis here. So in univariate analysis, each of the time we only put 1 variables into the regression models. But just now we already see the problems of confoundings because we know that patients who use antiviral treatment were older. So that's why we have to do something called multivariable adjustment. So at the same time, we put age, gender, and also the antiviral treatment into the same models to see the effect. And we can see that actually the antiviral treatment effect was taken away. So maybe, or in other words, actually the difference in the antiviral treatment on fracture risk can be explained by the difference in age in the data set. So that's why when we adjust for the age, we can now see that the antiviral treatment effect was no longer associated with a higher fracture risk in the multivariable model. So that's a simple way to handle confounding. But how about if we have many, like you will imagine a very, very long table, so you can adjust every factors one by one, but it is ideally we can do that, but in reality it's very hard to do that because of the problems of statistical power. So just now Dr. Choi also mentioned about usually we assume that for every variable to be included in the multivariable adjustment, we should at least serve them like at least 10 events to make sure that the variable can be reliably put into the model without exhausting the statistical powers. And statistical power may not allow multivariable adjustment for many confounding factors. But if you know there are many confounding factors and you cannot adjust them all, so there will be a problem of residual confounding. So that's why we have to go for something called propensity scores to balance the treatment group. So here I try to explain it in a more intuitive way. So propensity score, in fact, it is a probability. So it also ranges from 0 to 1, which document the chance of assigning a treatment to a patient given their clinical characteristics. For example, based on the patient's current age, gender, the HBV viral load, and the disease activity like the presence of cirrhosis, etc., we will determine the chance that the patient will receive an antiviral treatment. So in every patient, we can calculate such a probability using a regression model. For example, a logistic regression model. So we can input all the things that you think is important for the outcome and also important for the treatment. You can put into the regression model, and then you calculate the propensity scores, which is the probability of patient who receive a treatment. So and then what we should do after we calculate the propensity score, we match it. So why we should match the propensity score? Think of that. So for example, on my right-hand side, I have a group of patients with antiviral treatment, and on my left-hand side, I have a group of patients without antiviral treatment. So first of all, I take a patient with antiviral treatment, and then I calculate the propensity score to be, let's say, 0.5, let's say. So the chance of this patient to receive antiviral treatment was 0.5. And finally, in reality, this patient really received the treatment. Okay. And then the next step is I go to the part of the group that without antiviral treatment at last. And then I search for someone who also have a propensity score of 0.5. And then I pair up these two patients. So what I get now is a pair of patients, one with treatment and one without treatment, and both with propensity score of 0.5, right? So what it is doing is that it is mimicking a situation that two patients come along, and then they both have a similar chance to receive a treatment. And eventually, one receive it and one do not receive it. So it is mimicking the things that we are doing in RCT. So when two patients comes, we randomize, one of them receive treatment and one of them do not receive treatment. But of course, in observational study, we cannot do randomization because the treatment is already decided for each of the patients. So we try to do something called propensity score matching in order to mimic this kind of situation. So we make sure that for those who treated and those who untreated, we match it with a similar propensity score so that at first they have similar chance to get the treatment, but one get it, one did not get it, so that we can be more fair about the treatment effect on the clinical outcomes. So ideally, if you have adjust for everything in the propensity scores, it will be as if we are doing two randomly assigned treatment arms, and then we compare it on the future outcomes. Some methods for balancing propensity score include matching, weighting, stratification, and covariate adjustment. But I would say matching and weighting would be more popular among academic research. And here is a volume plot showing you how we can match the propensity score. Before matching, you can see there is a large difference. And of course, you will imagine that those who were treated, they will have a high propensity score because they are more likely to be treated theoretically. But after we matching it, so we are now comparing two similar cohorts with a similar chance of getting the treatment, and eventually one get it and one did not get it, so that we can be more secure about comparing real treatment effect between the two groups without like care about like those residual confounding problems. And finally, this is the result. So I get these results from one of the paper by Professor Grace Wong. So they compare treated patient and untreated patient on the bone toxicity. So they found that after propensity score matching, the chance of hip fracture and also other fractures are similar between the two groups, up to 7 years. So here comes to some interpretation of the findings from big data analysis. What we know about big data analysis is that p-value can go quickly to 0 when the sample size is very, very large. So for example, on the left-hand side, this is the original multivariable analysis that I showed you. And imagine if I increase the sample size to a very, very large one, and you can still get the same effect estimate. But at this moment, your confidence interval will be very, very narrow because of the big sample size, and the p-value, of course, very small. So we will have to interpret the results very carefully. Instead of just looking into the p-value itself, what we have to think of is the effect size. So for example, here, antiviral treatment, whether the hazard ratio of 1.05, that means a 5% higher risk of fracture. Is it clinically meaningful? Or if I give you another additional information, is the hazard ratio for fracture in the future 20 years? So will you still think that like 5% is a clinically meaningful difference? Or for example, I have a patient that is 40 years now. After 20 years, he's already 60 years old. So, or in natural like history, of course, the patient already have a higher risk of fracture because they get older. So you will have to judge whether the hazard ratio means a clinical meaningful difference between the treated and untreated patient in the context of your research, but not only look into the p-value itself. We have a problem called too big to fail in the large sample. So imagine when the p-value is first invented and popularized, actually n larger than 30 is already big in sample size, but of course nowadays 30 is not that big anymore. So we have the chance to like conduct study with very large samples. So for example, more over 10,000 observations. So again, the p-value can go to 0 very quickly in large samples. And if we only relied on a small p-value to explain your results is statistically significant, that would not be enough anymore, because you have to look into whether the effect magnitude is also meaningful in terms of like in terms of your clinical context. For example, I'm comparing treatment A and treatment B on the outcome of like overall survival. Maybe you found that in 20 years, the difference is significant, purely very small, but the effect magnitude is only 1% difference in the risk of death. So at that time, you have to judge, whether 1% really meaningful to our patient population. So focus more on the point estimate, confidence interval instead of only the p-values. And finally, we have to be careful about our sensitivity analysis and the so-called subgroup analysis. So sometimes when you read some like clinical paper or like research article, you can see a lot of p-value presenting in the results section, including the supplementary materials, table 1, 2, 3, 4, 5, etc. So that may not be a good practice in general, because sometimes we may get a chance to get a p-value less than 0.05 if you do more and more and more and more. But actually, we are exhausting our type 1 error in terms of getting a significant p-value out of a lot of comparisons. So we have to limit the number of comparisons to obey or to appreciate the statistical power that you have in the original samples, so that you don't run into the problems of p-hacking. So in summary, so statistical analysis can help us to understand the target population by analyzing data from a sample, 3 ways, including descriptive statistics, statistical inference, and prediction. I don't have time for prediction for today, and in future occasion, hopefully, we can share more about prediction. And graphs, helpful for data exploration, and we should avoid excessive hypothesis testing, and confoundings have to be adjusted before making fair comparison. And I also want to introduce to you IDDF 2024, which will be organized in August this year. So feel free to submit your abstract, case report, and to compete for our Young Investigator Award, and also travel grant with $500. So the deadline will be the 10th of May. So feel free to join us. And with that, thank you very much for your kind attention.
Thank you, Professor Ip, for your very informative lecture. You almost covered the entire aspects of the statistics in a short period of time. I was so impressed. And actually, I have learned a lot about the coloring of the figure. And I always talking about with my young colleagues, do you have a key figure to represent your study? And it's quite important to be cited frequently. So unfortunately, we are running out of time. So if you have any questions, please ask him personally. Thank you. I'd like to close this morning session. Thank you very much.
Thank you very much.
Yeah. We're going to have a lunch box outside this room. You can take the lunch around here.
Before you run out to get your lunch, let's talk about the afternoon. We have breakout sessions. So I hope everybody knows where to go, right? There are 4 rooms. And on the program, the ASLD faculty is not shown. So Professor Su will be in this room, room 5, for HCC session. I will be in room 6. Professor Iwakiri will be in room 11 for cirrhosis. And Professor Sabo will be in room 12 for muzzle and alcohol. So please be aware of where your room is. It looks like most of the sessions will be done by 4:30. So let's regroup here at 4:30. We have 2 talks, and then there will be awarding ceremony after that. So please show up at 4:30 here. Thank you.
Yep. So this is a score sheet for 9 presentations.
Thank you. Thank you. Oh, ありがとうございます。Hi, how are you?
I'm Edie Fan from Taiwan.
Mm-hmm. You're with Professor Lee.
Yes.
Okay.
And she told me that I have to agree.
Okay.
I really thanks for your presentation this morning.
Thank you.
Because I'm doing some research like our study, and I usually think that maybe I'm just doing the data analysis and that's all. But I think you let me know the importance of my study.
Study design. Yeah, design is very important.
Yes, but usually I always focus on the analysis process. So I think, I'm just taking computer and then.
No, so observational study is no different than.
そもそもわかんない。これ、ほんまね、3チップ色が全然